last week for 3 independent member roles, and recommendations will shortly be going with the supporting information to the Minister for approval. And thirdly, the launch of the Board Development Programme facilitated by the King's Fund, which its first session involved the whole board. This week there were separate sessions for the executive team and the independent members, and we come back again in October. A couple of other things I wanted to mention too. The first was that I, with Jill, attended the Recovery Coordinating Group meeting last week with our partners, which is a regional forum. And following that meeting, we provided a report to the Regional Leadership Board last Friday. And there, the chair and I agreed that I would ask Joe and one of the local authority chief executives to lead on agreeing how we escalate certain matters to Welsh Government. Joe, did you want to give an update?
Thank you, Chair. Yes, the conversations continued with all local authority chief executives and myself last night. The agreement is that we will use our silver group, which has been set up as part of our emergency preparedness planning infrastructure across North Wales, to develop a range of proposals that would be suitable for immediate implementation to ameliorate pressures that are being faced in domiciliary care, in residential and nursing home care, within our own hospital bed base, and all of those things taken together will have a positive impact on our colleagues in the Ambulance Trust. We are meeting as we always do as a group of senior leaders in pandemic preparedness mode, response mode rather, on Monday. And the intention is to spend some considerable time at that meeting signing off proposals that we would intend across all North Wales to begin discussions with Welsh Government. So we're hopeful that we will be able to collectively think of a small number of interventions that will have a positive impact for the people of North Wales, patients and residents, whilst being mindful of potential longer term implications. Thank you.
Thanks, Joe. And as you've alluded to, the intention here is not to shift things up to Welsh Government to resolve unnecessarily. We're keen to ensure that as partners in the region, we respond to the considerable pressures on the health and social care system, but there are some areas where we need Welsh Government support to be effective. And certainly, Joe, you've alluded to this too, from my conversations with the Minister and NHS Chief Executive, I think they're keen to help us wherever they can. So finally from me, to note that yesterday, a meeting was held, which I think was supportive but challenging, with the tripartite, i.e. Welsh Government officials, Audit Wales, Health Inspectorate Wales, to review the current challenges in terms of mental health and CAMHS, to consider what actions were in train and what actions are planned. And certainly I found the meeting myself very useful in terms of providing assurance around where we are and where we're going. And the involvement of those tripartite partners in that meeting, I thought, was also helpful and productive. So they're the updates from myself. We now come on to the report from Joe, which is the next item. The Health Board is asked to note the report. Joe, though, is there anything you particularly wanted to highlight?
Thank you, Chair. No, the paper is there for noting. I'm very happy to take any questions, just be mindful of time. Thank you.
Okay. So I don't have any hands raised. Thanks for your report, Joe. Always helpful to receive that and an update on progress in various areas. So I'll move us on then to the Targeted Intervention Improvement Framework. Joe, do you want to lead this item and then come on to Jill?
I would. Thank you. Thank you, Chair. I would like to propose that we agree that the executive team will take this paper back for further review and re-presentation to colleagues at our next board meeting. I do think that we have an opportunity to reflect more fully on the range of activities that have been undertaken and are in train with regard to our targeted intervention progress by representing the paper to colleagues at the next meeting. We are supported by colleagues from the Good Governance Institute today, and Louise and I are meeting with colleagues from the Good Governance Institute later on this afternoon. And just to remind all board members that one of the outcomes from the engagement with the Good Governance Institute is the creation of an independent oversight and review, not only of the evidence that we use to think about our maturity matrices scoring, but also to make sure that we're consistently applying evidence and using that evidence to create scores across each of our maturity matrices. And it is my intention that we are all able to take assurance from that independent view. Thank you.
Thanks, Joe. Jill, anything you wanted to add?
No, thank you, Mark. I think Joe's covered that very well. Thank you.
Okay, just from me before I bring Cheryl in, I'm not alone in expressing concern that the report does not truly reflect the activity that's either underway, has been completed, or is planned. And I think it's important, isn't it, that we are in a position where we have confidence in the report, because this is a key area for us and we want to be seen, as well as ensuring we are doing all we can to secure the improvement. So a more rounded report next time would be much appreciated. Cheryl.
Thanks very much, Chair, and thanks, Joe, for expanding further on this. The report really doesn't cover reflect the amount of progress made with mental health and CAMS, and also I think we need to touch on the much improved relationships with our partners. I'm seeing much greater engagement with our local authority partners. And of course, we're now facing unprecedented demand for our CAMS and our mental health services, and these improvements need to be continued with pace and focus. But thanks to everyone who's working so hard on this. Thank you.
Yeah, Cheryl, thank you. So we'll move on then. Jill, if we may, onto the COVID-19 update, please.
Thank you, Chairman. I'm going to attempt to share my screen.
Okay. Big test.
And we see that.
Yeah, are you able to expand it out, Jill?
I am trying to do that. Is that better?
That is wonderful. Thank you. Yeah.
Okay. Apologies, I'm not in quite the same technical camp as some of my colleagues, so apologies. So just to give people an update, and I'm going to do this with the inclusion of the points I want to pull out of the report, if that's okay, Chairman, just to ensure that we can do this as timely as possible.
Oh, thank you.
So in terms of the presentation, this is an update in terms of where we're up to with the COVID situation across North Wales. And to be very clear, this hasn't gone away, it's very much with us. So what you can see is that community levels remain high, and we are seeing transmission across the health board, across the North Wales, whole of North Wales, and that is impacting on our services across the board in a number of different ways, not least staff isolating, frontline staff having to isolate, not being able to join our front line, and of course the changes in social, the reduction in social restrictions has impacted highly. You can see on this slide that we are seeing the confirmed cases by age. You can see that is increasingly in the lower age groups. And this slide starts to describe what we've got in terms of hospital inpatients. And again, I think you can say that although the acuity is not necessarily as high it was in the second wave, we are seeing a big impact as a consequence of COVID within our hospitals. And to be clear, Chair and Board, this does impact on the beds that we have available to us, because clearly we need to restrict our beds to ensure that the best protection for transfer of the virus is maintained. And that does mean that we have had to remove beds to ensure that we meet social distancing requirements. We have had some healthcare acquired infections, and I have told this board previously that unfortunately I think this will continue to happen. We had an outbreak declared in Ysbyty Gwynedd. That is now closed in terms of the number of patients that we're managing, but we do continue to report in line with the best practice and public health guidance for 28 days. But the cumulative total of patients was 35 of definite or probable HCAI, so that is healthcare acquired. We also have had an outbreak declared at Ysbyty Glan Clwyd and Llandudno on the 8th of September. We are working with the strategic outbreak team to manage this, and there are now 27 patients and 9 staff probable or definite HCAIs as of the 20th of September. And we do know that the impact of our ED departments, the crowding in our ED departments is not helping some of the transmission. So we are doing some enhanced work within our ED departments to ensure that we're maintaining the best protection for our staff and patients within those environments. We have had some decisions made at EIMT. They are there for people to see. I think the ones I would like to pull out is the reinstatement of restrictions in visiting for those areas where we've got high level of infection, so where we have defined outbreaks. We have approved the standard operating procedures for the vaccination programme, and I'll come on to those. But the other ones I'd like to pull out are the ratification of planned care cancellation. We are seeing an increase in planned care cancellation, and we are strongly prioritising the planned care and elective care that we undertake. And that is as a consequence of beds being available in green, so very clean areas for the patients to be able to recover. We're also working, and Joe alluded to this in the conversations regarding partnership with our local authorities. We are looking at how we can explore different ways of working to support our local authority colleagues regarding the staffing pressures that we are seeing both within domiciliary care home and our own environments. Test, trace and protect. Teresa, do you want to pick up these slides?
Diolch yn iawn, happy to. Mae'n Gymraeg a carry on in Welsh still. O ran yr gwaith profi,
as far as the testing, the work is increasing.
Teresa.
Hello, can you hear me?
Sorry. Yeah, sorry. I've just been advised, Teresa, that there's a problem with the translation link on YouTube. Given the importance of this topic, I suggest we just continue in Saesneg for the moment until we know that it's up and running, or so some of those viewing will not be able to follow what you're saying.
Oh, of course. Apologies, everyone. So, are we testing? So the demand is currently unprecedented for us in North Wales. Systems are coping well, but it is challenging. And in a way, it is good to see that people are following the message to go and get tested, but the volumes are high. Tracing, I have to say, the teams, and it is a regional partnership approach on tracing. Teams are doing well, despite some of the hard messages. Not everyone wants to be traced at this moment in time. That's been reported in the media. But again, through the partnership arena across North Wales, everyone's trying to pull together. We have had to prioritise, but working well. And then on the protect work, we're now going ahead with a sixth of the COVID hubs, which is great news because we talked earlier of long COVID, but COVID equally has those short-term impacts now. And so being able to wrap around our citizens is important. And I think we're doing well in Wales to have 5 already, but being able to have that 6th in Conwy is excellent news. And then from a risk perspective, certainly capacity is probably our biggest issue. Similar with Jill, we've discussed quite a bit on recruitment and workforce on a number of occasions, but we'll just have to keep focusing on that. I think it's going to be a challenging winter, but there are potential changes, of course, as we go into this next phase and winter in general.
Apologies, I'd muted for Teresa. So pick up on the vaccination programme. We've given well over 1 million vaccinations, vaccines across North Wales, and that includes significant, nearly 500,000 second doses. And I'll remind people that we are now calling people forward for their third and booster. So this slide shows where we are against each of the initial cohorts, and you can see that we've made fantastic progress there. And as an update, we are now booking in the 12 to 15-year-olds who are with underlying health conditions, and we will be booking in other 12 to 15-year-olds from the 4th of October. Our booster programme has commenced in fact, and BCU were the first in Wales to start to deliver the booster vaccination programme. So we are calling healthcare and social care colleagues, and care home boosters have already commenced. We continue to work with the hard-to-reach groups, and our maternity colleagues are supporting us and getting the message out to pregnant women who may feel that this is a difficult choice for them to make, to encourage them to step forward and have the vaccine. I do want to make the point, the risks across all of these programmes remain our staff. They're dedicated and committed and going well and beyond the call of duty in terms of managing the number of pressures that we're seeing across the system at the moment in unscheduled care, trying to deliver the booster programmes and indeed our TTP. I'd just like to take the opportunity, Chair, to thank them for the contributions they're making at the moment. They're doing a fabulous job in increasingly difficult conditions, and I just want to offer my thanks and support to each and every one of them. The other point I would like to make, Chairman, is due to the unprecedented level of pressures we're seeing in both unscheduled care as a consequence of the COVID pandemic, we have made the decision to step up, is highlighted in the report, to escalate our situation reporting levels, and that is being taken through our EIMT, which we have now stood up to 3 times a week. To support that frequency and enable us to make swift decisions, it was proposed that Cabinet was reconvened on a fortnightly basis, and the first meeting took place on 15th of September. This does allow us to have board representation on a regular basis, on a fortnightly basis, to ensure that decisions can be made in a timely way. So I just wanted to bring that to the board's attention, and also the hubs that are supporting the IMT, which is our intelligence cell or modelling and forward planning, operational response and surge planning. workforce deployment, communications coordination, and clinical transformation. And I'm happy, as I'm sure colleagues will, to support any questions.
Okay, before I open it up, the translation onto YouTube is now working, so we can speak in both Cymraeg and Saesneg. So any questions or observations? No, okay. Cabinet, as you say, Jill, what did meet last week? I thought it was a very helpful and productive meeting. Hope you did too. And we did underwrite, confirm, support those things that you wanted us to do in terms of changes and some of the more difficult decisions around planned care. Jill, just while I think of it, I don't have Cabinet in the diary for next week. I think we need to resolve that. I'm not sure who's arranging it, but we need to sort out a slot for next week.
I'll ensure that happens before I go and leave.
Thank you. Okay, so we'll move on again to the next item, which is maintaining good governance during COVID. Louise.
Thank you, Chair. So taking the report as read, really, it just follows on from some of the points that Jill made from a governance point of view, really. This report is a further report. Colleagues will recall these at several of our board meetings since the pandemic, which just seeks to provide some assurance that we keep governance and under ongoing review to ensure we can maintain responsive decision making, but within the appropriate parameters and board retaining sign off of all. We have, as said, reinstated the Cabinet. We approved that through a Chair's action, as Jill has referenced, so that enables us to respond to endorsed decisions made by the EIMT now it is meeting more frequently. We also continue to use Chair's action, which gives us some agility in decision making where appropriate, and we've just reviewed the operating procedure for that, which felt appropriate this time as well. We're also, just to say, reviewing the terms of reference for the Cabinet as well, just to ensure that that sort of remains fit for purpose, particularly around the membership. In light of the sort of recent escalation. Just the last point I think to make is obviously we are moving towards, or we're in the implementation now of the governance review, which was approved by the board in July. And of course, practically that means this sort of transition of the committees and the new business cycles. But we are continuing to retain a view on the sort of the business flowing through the committees, to ensure that should we need to look at committee sort of pressures as time moves on, that we retain the rights and the ability to do that, alongside, of course, the committee chair and the executive lead. So I'll stop there. Thank you, Chair.
Thanks, Louise. Very clear. So the board is asked to note and support the update outline and the governance arrangements now in place. Are you happy to do so?
Yes.
Yes.
Yeah.
Yes.
Okay, thank you.
Yes.
Thank you. So we move on to items for consent, which I'm going to seek to move accordingly. So the first is the Mental Health Act update in terms of the various provisions. It's recommended the Health Board accept this report as assurance of compliance with the process and procedure. Are you happy to do so?
Yes.
Okay.
Yes.
The next is the WUSC paper. This paper doesn't directly affect BCU commissioning, but is within the full consent section, as it still needs ratification. Are you prepared to do those things listed at 1 to 4? I.e., the first is to note, the second is to approve the delegation, the third is to approve WISC developer service specification, and the fourth is to approve the delegation of paediatric orthopedic surgery commissioning. Are you happy to support 1 to 4?
Yes.
Yes.
Thank you. Okay, so we will move on again to item 3, which is developing the new strategies or plans section of this revised agenda, i.e. the future. And the first is associated with the refresh of living healthier, staying well. Chris, over to you.
Thank you, Chair. The board is being asked to receive an update today on the work that's underway, refreshing our long-term strategy, which, as you've referenced, is living healthier, staying well. I'm going to take the paper as having been read. It's 3 years since the original Living Healthier, Staying Well, It was felt by many to be time to retest that document, not least because a Healthy Wales has come along in the meantime. And we are very well aligned with that, but it was an opportunity to refresh things alongside COVID and the implications of COVID that we have rehearsed in many meetings. If colleagues or members of the public go to our board website, they will now see a section on the refresh of Living Healthy, Staying Well. And we've got a month, or roughly a month's period now ahead of us, where we are actively seeking further comments in terms of the refreshed document. The refreshed document can be found on the website alongside that form to be able to provide feedback, and our engagement teams and partners are out and about seeking further thoughts. As we move this through, we'll then be in a position to move through some of the work on a number of other strategies and plans that are underway within the Health Board, not least how we translate Living Healthier, Staying Well and a Healthier Wales into our clinical services plan going forwards. I'll stop there and pick up questions.
Lucy.
Thank you for that update, Chris. The document is referring to the refresh being used to inform a clinical services plan. Where does the clinical services strategy fit in with this? I'm not clear what the difference is between the plan and the strategy.
Okay, so I think that's a challenging question, Lucy, because you are highlighting some debate which we're also having in terms of how the various different pieces of work fit together, and what is a plan, what is a strategy, and how do they all align. The strategy for the Health Board is not a linear process. There'll be various bits to join in, and other partnership strategies, for example. And some of our plans are quite strategic, and some of our strategies are quite operational. So we, as we move through Living Healthier, Staying Well, are seeking to align those other pieces of work in a more coherent jigsaw to help answer that question. You may have seen in some organisations a strategic plan on a page, which is a little bit like a pyramid, which kind of aligns the different levels of strategy and thinking. And as we move through and into the workshop for board members at the end of this month, we want to rehearse some of that with you to answer exactly some of those questions.
Okay, so it's not that we're still looking to develop a clinical services strategy in and of itself then?
We are looking to translate Living Healthier, Staying Well into a narrative which outlines exactly how our clinical services will be delivered. Whether that is a clinical services strategy plan or whether the two come together is some of the conversation we want to test with board members.
Okay, thanks.
Jo, then Lynn.
Thank you. So colleagues will remember when we met on the 4th of February, we discussed a broad framework for the work that we want to do. So we talked about strategies, plans, strategic frameworks, and all of those sorts of things from the point of view of our purpose and our values. We described creating or refreshing our Living Healthier, Staying Well as our strategic framework, within which, or that would then create a framework within which a series of plans were developed and implemented. And at the workshop on the 4th of February, we talked about strategic plans and we talked about a clinical services strategy or plan. The purpose of the next set of conversations, as Chris has outlined in workshop mode, is to move those conversations forward so that we can agree a naming convention for strategic plans, implementation plans, and so on, so that when we talk about a strategy or a plan, we are clear but what we are intending. The emerging thinking with regard to the clinical services plan at the moment is underpinned by a strong focus on the development of enhanced cluster-based working, as well as trying to think about making sure that we're able to define clearly what we see as the core functions of our acute hospital sites, as well as being clear about when we are looking to provide more specialist services, perhaps in conjunction with conversations around repatriating of care from the Northwest. We're clear about what are the circumstances when we will be operating in hub and spoke mode, and what are the circumstances when those services will be provided at a range of levels, including at enhanced cluster level. So as Chris has said, we've got a further opportunity at our next workshop to try and coalesce around, when we say these words, what do we think these words mean, and how will those subsequent conversations with the staff and population of North Wales help us to create a strategic synergy for the services that we provide, fit for purpose now, but also into the future. Thank you.
Thanks, Jo. Lynn.
Thank you, Mark. There is a number of key themes, and what I see is missing is the population health needs and the preventative work. Is that implied as opposed to being explicit?
That's a really good point, Lynn, because it is very fundamental in terms of the thinking through this, but it is too implied within it, and we probably do need to call that out. Yeah.
Okay. Thank you. That I would appreciate that. There's reference to an engagement team. The engagement team commissioned an annual perception survey. Can I assume that the third sector are key players in this?
They are.
Okay, thank you. Because we absolutely need them. Thank you.
So just in that regard as well, Lynn and Chris, before we finish, I would anticipate with the appointment of a new third sector member, one of their priorities on our behalf will return to what our strategy is in terms of working with the third sector, which, as you know, Lynn, has been discussed at points at your committee.
Yes.
We'll need to return and resolve that subject following their appointment.
I think it's more essential now than ever before. Thank you.
Yeah, I agree. So Chris and Jo, just to be clear, because I wouldn't want people to think we're about to have workshops that might represent dancing on the head of a pin in terms of what we're going to call things. What we're seeking here is a clear sense of direction now and into the future, so as to inform a medium-term plan which we're committed to producing towards the end of this year and for the next 3 years for the first time, for a long time as a board, and to, in doing so, shape the future of our clinical services and how we wish to see them transform along with other areas of transformation. Are we content that that is our ambition and commitment here?
That is exactly what is intended, Chair.
Okay. The other thing is that the independent members you heard earlier on had a session with the King's Fund yesterday, who spoke about us as a group talking about our purpose when we next come together with them. In keeping the conversations I've been having with Jo and others I said that needed to extend to where our ambition lies. And I think that is as important as being clear about our purpose.
Yeah, okay.
Right, okay. So I'll move us on again, if I may. And I'll assume that the board is happy to receive the update on the work underway, which we've just discussed for that item, onto unscheduled care. And Jill, this is with you, but I understand Chris was attending too, Chris Subi.
He is, Chairman, but if I can take you through some of the highlights and the context, and I alluded to this within the COVID update. So we are seeing significant pressures across the whole of the health board at the moment, and indeed our health and social care partners, our local authorities, are seeing increased pressure. Part of that is down to a lack of resource, so our staff in domiciliary care, part of it is down to the pressures we're seeing. And although our numbers that are attending our EDs are just coming up to previous levels prior to the pandemic, what we are seeing, and this is probably as a result of some of the impact of behaviours within the pandemic, is the acuity is increased. And clearly some of the concerns we've had about patients stepping forward during the height of the pandemic, we are seeing a rise in referrals in some of those areas. What I'd also like to say is that has meant that we've had to surge our beds, and we're doing that regularly to ensure that our patients have access to a bed as quickly and promptly as we can. That has meant, and it has had an impact, and I know this is something that I suspect Chris will want to pick up, on those GP immediate access beds, so our STEP beds, our assessment areas. And there's work in train to support opening of those, but also to ensure that we've got clinical standards operating across the whole of North Wales to ensure that these remain units remain available for our GPs and direct referrals, and that will also have the impact of reducing the footfall in our ED. And as I've alluded to earlier, there's quite a lot of work going on there to ensure that we maintain IPC processes to limit the impact there. The improvement plan is ongoing, and Chris chairs a weekly meeting with clinical leaders, not just medical leaders, it's therapies and nursing colleagues, to actually consider how we can put in place the improvements that are required, but also how we can monitor the impact. I'm sure he'll take you through the dashboard that's been created. There has been a focus particularly, and there is an ongoing focus on ensuring that we have our board rounds in place and that those are coordinated effectively and consistently across the health board. I alluded earlier to the fact that we have lost beds in an area where there has been transmission of COVID, and that has impacted, again, our unscheduled care performance. We are working with local authority colleagues on medically fit for discharge patients to ensure that we can allow our patients to get back into the community as quickly as possible, because we acknowledge that keeping them in a hospital bed is absolutely not the best place for them. But Joe alluded to that earlier in the board, Chair, so I won't go into that in detail. I think, Chris, you're on the call. I don't know whether there was anything you wanted to add before we go to questions.
I know Kate was trying to get hold of Chris and just text him, Jill, but Chris is working in an ED at the moment, so he may not be with you.
No problem. I'm happy to take questions.
Teresa, did you want to come in first?
Thank you, Jill. I only wanted to mention Lynn's point earlier about the health of the population. When we're talking about unscheduled care and some of the work that we're doing, at that time, we have to think of the path for health of that patient. And if our aim is to keep the population as healthy as possible, as Lynn mentioned the work about the strategic steps, there is an opportunity when we talk about the unscheduled care agenda to ensure that we give enough focus to the preventative so that we can keep the patients at home and closer to their friends and family and neighbours. And I think that is a part of the strategy as a health board moving forward. So I was very grateful to Len for mentioning this earlier, but as Jill presented, I was just thinking, yes, it's true. This is a case where if we can put a focus at the front or at the beginning, we will see some improvements, and it'll enable the community team to be working with the patients that need that higher care. I just wanted to make that comment really, and I'm very grateful to Lynn for giving me the nudge, and I think we're on the right track. Looking back at some of the priorities of the ministers, some of the preventative work is there, but I know it's not just keeping people well, but it will help the system to work, and then the system will hopefully give the right focus, and there will be enough capacity then to help the patients that need the more intense care. Thank you, Chair and Jill.
Diolch yn fawr, Teresa. Morwenna.
Thank you, Chair. I just wanted to add a few comments in relation to social services and care generally. I'm not disagreeing with any comments made. It is a challenging situation, a very challenging situation across the country. And Wales and this region is no different. But just to provide assurance really to the board that there is regular discussion between local authorities and the partners and the health board in relation to some of the possible solutions that can be put in place. And I must be honest, I think that many of them are already in place, and there aren't any easy answers to this. And we, as directors in the social services, are regularly discussing with the government and trying to find ways forward. We are, of course, accepting as a region grant funding, and this is often temporary funding, but it's a situation where I think that funding doesn't necessarily solve everything, because it's very difficult to get the most important thing, which is the staff and capacity. But I fully and entirely agree with what Teresa has said, that it's important that we work in partnership here as providers, but also in our communities to ensure that we can keep people well and at home and avoid hospital admissions if possible. I do think, and I do emphasise, there's many of the problems that exist at the moment are a sign of the fact that we need much more strategic long-term solutions in care. And looking forward, of course, to those discussions with the government, and hoping, as the health board, I'm sure, that we can play our part to ensure that social care is a healthy one for the future. Thank you, Chair.
Diolch, Morwenna. I certainly got the impression from the conversations the CEOs were having, and also at the recovery coordinating group last week, that there is a real strong sense of partnership and looking to see how we can address the significant pressures of across both health and social care together. And I do think that the request that you've been making with your colleagues about social care of Welsh Government, along with those parallel requests we're making, should have I would hope, the desired impact. So thank you, Morwenna. I will come to Jill, then Lucy.
Thank you, Chairman. Some of the areas I was going to pick up have already, so thank you, Teresa. I think one of the areas I would want to emphasise is the improvement plan is whole system. It does include working with partner agencies, and it does include the prevention piece. The other point I wanted to add is we're working closely with WAST as well to look at the opportunities we can work through jointly. Now, we do know that we have a high incidence of falls, patients falling at homes, ending up in our ED departments. So that is an area that we're focusing on, but we're going to be working collaboratively with WAST and partners, including the third sector, to see how we can prevent these people coming into our EDs, but equally how we can continue to support them in the home. The other areas that we will be looking at are around respiratory pathway and chest pain. And again, these link into the opportunities that we're pursuing around our SDEC or our short stay assessment areas. But the other point is that we're working to realign our MIU pathways, and this is going to be a longer piece of work to ensure we've got consistency across the patch and to ensure that our ambulance colleagues are confident that they can take patients to the MIU where that's appropriate, and that they will have the appropriate care there. So this is a whole system piece of work, and most importantly as well, there is a considerable thought going into how we include our public and patients, not only in the communication, but in the decision making. I know that if Chris was here, that is an area that he would be calling out.
Thanks, Jill. Lucy, then John.
Thanks. So I've got a few questions, so I'll ask the questions, and then if you need to clarify anything, then please do so. So the report states that an increasing proportion of patients are being admitted through the emergency department. And some of our clinicians have said that a proportion of these patients presenting via the emergency department are because there's no alternative pathway available for them to be seen rapidly. Has the analysis included the reasons for patients presenting and being sent in against pathways to highlight the gaps? My next question then is, how does this improvement programme fit in with previous improvement initiatives? Because we've had some relating to unscheduled care before. Then, given it's October next week, how confident are we that sufficient improvements will be made in time to impact upon winter pressures? And then my final point is that the report and the work streams, as described, are very primary care light. And if we are taking a whole system approach, we have to be looking at the service that sees around 80% of patient contacts, but it's not mentioned in any of these work streams. Thank you.
So, Chris, welcome. Probably joined just at the right time, Chris. So I'll let you go next, and I'll bring Jill in after you.
I'm just wondering, I apologise, I just literally dialed in, so I didn't get the full gist of those questions. Do you want me to come back to those after, or do you want me to answer those now?
Well, let's start with anything you particularly want to say yourself, Chris. And then I think the thrust of those questions was, Lucy, correct me if I'm wrong, we've been here before, how does this improvement programme fit in with previous improvement programs, and what can we learn from that? Primary care does seem to be absent in terms of the paper, what is going on with primary care to assist with flow, and then the concerns about whether there is truly an alternative pathway to in terms of emergency care, which is not the ED department.
Yeah.
Spot on. Thank you.
Okay. Hi, my name is Chris Subi. I'm a consultant in acute respiratory and critical care medicine, and a senior clinical lecturer at Bangor University. And I've recently taken on the role as senior clinical lead for the unscheduled care program. I might want to spend 3 or 4 minutes to give you a brief update since I was last here to what we have done, and it might address some of the concerns that were raised around the scope and effectiveness of the program. and just in terms of timeline, we started at the beginning of July. We spent a month of trying to understand the problem with my colleague Roshan, and supported by others, and have then started to focus on key areas that we think are potentially in our gift and might be feasible for a timely intervention. So those are important caveats, and we might have to come back to this. So there are 4 work streams. 2 of them are located in the community. 1 is at the interface between community and hospital, and the 4th is in the hospital. So work stream 1 is the step up in the community. As a suitable intervention, we identified upskilling of the minor injury units as something that, as the data told us, there's been a move of patients from minor injury units into emergency departments on all 3 sites within the last 2 years. The intervention that we identified is upskilling and standardizing the level of cover from emergency nurse practitioners. And we've now undertaken a skills gap analysis, and we've got educators from both Bangor University and Glendur University who are supporting us to deliver this program. There is a buy-in from the emergency departments to try to have a more collaborative working between those different departments to benefit from skills and knowledge that's already in the system. With regards to the work stream at the interface of the hospital door, in line with what colleagues around the country are doing, we've identified pathways and capacity in same-day emergency care as the key challenge for the trust. And we've identified a number of pathways, and we're now working with colleagues to see how the communication around these pathways needs to look like. And we've submitted a business case, and we're working on staffing patterns for those units to allow them to take a significant larger proportion of the patient than what they're seeing at the moment. And in fact, I spent this morning in the emergency department of the Spitteglang Clwyd to look at how some of those patients that are at the moment presenting to emergency departments could be supported in same-day emergency care units. The 3rd work stream is the only one that's inpatient focused, and that's around having more efficient and effective working in the ward teams. And we've identified a pattern for board rounds and criteria-led discharge as the intervention that we need to deliver. We've got pilot sites now running on all 3 sites. We've got educational interventions that are in progress, and we're hoping to see effects of this. We have, for the last 2 weeks, been able to give the wards that are involved in this weekly data, and this is a resource that's freely available online, where wards can see how they've done and how they've done in comparison to wards from the same specialty in our sister hospitals, and in comparison to other wards in the same hospital. And then the 4th work stream is around the community support of patients who by and large have got frailty. So these are elderly patients who will need for a period support with activities of daily living. And we've standardized the nomenclature across the different community and hospital teams that are supporting these patients, and focused on the role of the trusted assessor to have a equitable system that allows us to identify those patients who require most that support and be prudent with our limited resources. In response to the question, of course, the majority of care is delivered in primary care. And we have got primary care representation in the 3 work streams where this is relevant. And we're working very closely with colleagues in primary care. There are challenges in capacity in every part of the system. I think it's important to acknowledge that. So therefore, there will be a tendency to try to bundle some of those challenges in locations. sometimes wrongly in emergency departments, we want to go away from this. So there are other interventions that will require more planning and probably some investment in the community. But those are the things that we thought we could do in the next few months to give us a fighting chance to make things slightly less bad for patients that we are being supported in our area. And I'm just wondering whether I should take questions now.
Before we do, I've got several others coming in. I know John has been waiting patiently for no doubt to ask some questions, but I'm going to bring Chris and Jill in first, and then I'll go to John, and then I'll open it up for other questions. So Chris, then Jill, then John.
Yeah, thank you, Chair. Just building upon Chris's response to the observation that that Lucy made in terms of the primary care component. I think it's an interesting point. On looking at the paper at face value, you could say that the paper is relatively light from a primary care perspective. I think there are some reasons for that. I think there are things we can do differently in terms of increasing the words on the page with regard to primary care, but I think there are good reasons for it. And as we move more and more in the direction of a truly integrated organisation, we're not always going to see the words primary care and secondary care explicitly drawn out as they become increasingly weaved together. And one example of that in terms of the unscheduled care work and the SDEC work that Chris has just mentioned, so the same day emergency care work, it is his reference to pathways, because we're absolutely clear, and Chris is absolutely clear, that that pathway work will follow the methodology that we have agreed as an organisation for our pathway transformation going forward. And the very reason that we agreed that was because we wanted to move things more left into community settings, understanding the primary care perspective and the community perspective and the public health and preventative perspective. And so all of that SDEC work, all of that work on those pathways will be done explicitly through the lens of primary care, as much so as through the lens of our emergency departments. The second point I guess I would make is Nick, Sue Hill and myself had the privilege yesterday of working through a range of applications that our primary care and locality colleagues were asked to put forward. One criteria for which was how they could contribute to this. It isn't called out within the paper because it only occurred yesterday, and the Dragon's Den session, which will follow on from that, isn't until next week. But it was absolutely clear through some of those applications how much our community services and primary care colleagues want to contribute to this and the ways in which we can enable that. As we move through that process, I will bring back to board the outcomes of it so that everybody is cited on some of the work that they are going to do. But just to reassure Lucy that primary care is certainly engaged within this process.
Thanks, Chris. So Jill, then John.
Chris has picked up some of the points I wish to make. I think the SDEC is a piece of work that we are taking forward as part of a business case, and the principle behind this is a rapid turnaround and support of patients back to their homes. But it also means that they won't be going through what is known as the emergency department. Chris and I are working on the principle, as with all the rest of the team, on an emergency floor, so that patients are signposted to the right care in the right place and the right clinician is there to receive them. The principles behind the same-day emergency care would see, we think, roughly 30% of patients that are currently going through our emergency department moving straight past that emergency department into that same day emergency care centre. So I think that would see a significant decongestion of our ED department. The other point I want to make is that our ET at the executive team yesterday, we discussed the increase in workforce capacity to ensure that our ED departments are appropriately resourced. That was agreed, and we'll be going through our normal governance processes. But Chairman, we're already in taking forward some of those recruitment. So the recruitment job descriptions, how we're going to ensure that those people are recruited in a timely fashion. That working group is already set up and is approaching that on a North Wales basis. The other point I would like to make, and it is something we've picked up alongside the board rounds, is we have seen an increase in the amount of patient moves. And that is absolutely within our control, within our acute sites, but also within community sites. We know that not only increases the risk of harm to our patients, but absolutely extends the length of stay that they experience. So there's work being undertaken there. And as part of the Cabinet, there is work being, to present to the Cabinet, there is work being undertaken between workforce and nursing in particular to ensure that we've got patients cared for in the right environment so we can maximise our acute wards for those that most need it.
Okay, thanks, Jill. And John, thank you for your patience. Over to you.
Thanks, Mark. I just wanted to draw out a question linked to Workstream 4 and the step down into the community. But I suppose ultimately it's relevant to all of the programme here. Given that we had clear strategy around care close to home, and therefore we would have had plans to deliver that in the past, and I'm assuming, therefore, that the step down in the community would have been covered to an extent within those plans to deliver. How do we have confidence that this work stream and ultimately the others are actually going to be delivering successful? What's different between our approach here and what we would have been tackling using the example of care close to home?
Would you like me to take that, Chairman?
Yes, please, Chris.
We are not in simple times. I think you probably heard the news this morning that there is some serious concerns about delivering care closer to home across the whole UK. And if you ask me how confident I am, then I think we'll do as good as we can, and we'll try to give everybody a ray of hope that we can do this, but we know that we're in a very difficult situation. Just to illustrate that with two examples, I spent some time this week at the Patient Safety Congress where I was presenting, and Kevin Fong, who some of you might know from as well, represented questionnaires that he'd posed to doctors and nurses working in intensive care during the COVID unit. And 50% of nurses and 30% of doctors could have been formally diagnosed with mental health problems, including post-traumatic stress syndrome, anxiety, depression. And I think those of us who've been at the sharp end of COVID will sympathize with this. And I would challenge anybody to do the same exercises in other areas. And I think we'll find some very similar things. So we will be able to deliver what our teams are able to deliver. And I think the one thing that we've tried to do differently than some other previous attempts is to try to work as close as we can to teams on the shop floor. So something that I sometimes call microsystems. So to try to focus on things that everybody can contribute to and where we can gauge whether they are able physically and mentally to do that, and then build on that. to have large numbers of brains and hands supporting us on that. So I'm afraid I can't tell you. I'm confident that we're going to make major impact in a short period of time in a situation where we're talking about calling in the army. We're going to give this the best stab that we've got. And that can only be done by bringing those people together that have to deliver the work. I'm happy to take further questions on that topic.
So Joe, I know your hand is up. Having heard what Chris just said, is there anything you want to add? No, okay. So your hand is up, Joe. You still wanted to come in? You're muted. Okay, I'll take the hand was raised accidentally. So Jill, Chris, thank you for the presentation update. You'll see that, of course, this is an area of interest and concern to the board, and we're keen to ensure that we could do all that we can to support you and others in moving forward in the face of these challenges, particularly around the workforce. It's good to hear that the work around the workforce is now moving forward, and no doubt any investment requirement will be tabled at Finance Performance Committee, but I'm sure we'll be looking to support that. Can I just be clear on one point myself around the presentation and report, and that is the position around a winter plan. Previously, we have been asked for, haven't we, a discrete winter plan. I see this is referenced as being informed by this unscheduled care programme, but what is our intention around our winter plan, Jill?
So we are collating and we are working with Stephen Harris and Ruth on that plan, as well as our partner agencies to collate that plan. And obviously that will be shared with the board. But the principal pillars of that for our own internal purposes are that it meets the areas identified within our own unscheduled care plan. We need to be cognizant, Mark, of the workforce challenges that we have. Yeah. And that is actually being called out quite clearly, that we cannot assume that we can employ more personnel, albeit that we are looking at opportunities, as you know, how we can support partners around care in the community. So that plan is being worked on, Mark. I can give you that assurance, but it will. The basis of it is aligned to the improvement work.
If asked, Jill, when will we expect to see that winter plan? What timescale are we working to?
Can I take that offline? Because I haven't had clear confirmation from Welsh Government. So I will. I'll take that offline and let you know.
Okay. The final point from me is, so I know we've got metrics already. There are some metrics referred to in this update. Are we intending to do anything around the metrics that we follow? And will those metrics be reported to board in some way, shape or form?
Yes, so my intent, Chair, is to work with Sue, as I alluded to earlier in the board, to work with Sue H's team and the refined performance report work that she's doing to ensure that the appropriate metrics from the improvement plan are visible to the board and our progress against them.
Thank you. Okay, and thanks again to you and Chris. So the board is asked to note the update. I'm sure we have. We are now to move into a comfort break. Answer and Banned, time for a cuppa if we get chance. So we were due to break at 11:12. We're running 3 minutes late. So can we come back, please, online at 25 past? Thank you. Diolch yn fawr iawn.
Diolch yn fawr i chi.
Okay, are we ready to continue? So the next item is 3.3, which is sustainability and decarbonisation. Rob, I think you and Rod are presenting this. I'm conscious of the fact Rod wasn't here, but Rod, I asked colleagues earlier on to recognise that the paper's presentations have been read already, so you can assume they've been read. So can you and Rob concentrate on it you particularly want to highlight, and then I'll take us to the recommendations.
I'll just hand over to Rod, Chair. He's go through the paper.
Okay.
Thank you, Chairman. The paper, the paper sets out the response for Welsh Government in regards to addressing decarbonisation across the organisation, particularly sustainability. I suppose the points I wanted to bring out is that we're not starting from a zero base. There already has been significant work undertaken across the Health Board from both an estates and capital perspective. But I think the opportunity this presents is to broaden the context out to look at the overall organisation and control. I think at the board development session, we had the opportunity to talk and prioritise, and clearly the roles and responsibilities in terms of leadership of the programme were identified, the governance, the links to strategic plans, and really more importantly, the connections between clinical staff and staff engagement, and particularly grassroots. The programme and proposals are set out in the paper. We've already appointed the Carbon Trust to commence the data gathering. That work is currently running live, and we already have a number of decarbonisation programmes moving forward. We have, Chairman, taken the benefit of working with the Welsh Government's Energy Service in terms of developing the actions and plans, Specialist Estate Services, and also the Green Group. So the report sets out our direction. We've made progress. We've got funding this year from Welsh Government to deliver a number of decarbonisation schemes, and the programme seeks approval to commence in terms of framework and model moving forward. So happy to take questions, Chairman.
Yeah, Rod, any questions? Right, I've got a couple, Rod. The first is, just from a board perspective, Rod, it'd be helpful to understand where governance of this project is going to, or programme of work is going to lie. We'll need to agree where it's going to be reported to. Secondly, whilst I recognise this is, for want of a description, largely operational, this is a key priority. So I would like to agree, Rod, some IM involvement, independent member involvement and tie-in. And if none of my colleagues wish to do it, then I'm happy to do it, Rod, and be that link. And then finally, in terms of the plan, Rod, and the expectations from Welsh Government and our own expectations, I don't know where you stand in terms of thinking this through, but it'd be helpful to have, if you like, a roadmap of setting out when our delivery milestones are, so that we can have that to look to as we move forward.
Thank you, Chairman. If I take those questions in order. So in terms of governance, the executive lead is the executive Director of Finance, and the committee for reporting will be through our Partnerships, People and Population Health Committee.
Right, okay.
And they've already received an update report on our programme in terms of decarbonisation. In terms of an independent member to champion, absolutely, that would be consistent with what other boards are doing across Wales, so we would welcome that as part of the programme group. And in terms of roadmap, what we will have by December through the work of the Carbon Trust is a costed plan with timelines that will be our document and roadmap moving forward for submission to Welsh Government, because there will be some additional funding available in 22 and onwards to deliver some of these high-level objectives.
Okay, thank you. Teresa.
Diolch iawn, Cadeirydd a Rod. Dim ond sylw.
Thank you, Chair and Rob. Just a very brief comment, if I may. I'm very grateful for this work coming through. I agree that this is a priority for us as a board. This, for me, is a priority across North Wales, of course, and once more, we won't be doing this work alone, although there is work for us to do. There are opportunities with our partners. That work has already commenced across North Wales, and I saw in Rod's paper that there is a comment about active travel. And this is a part of the work that has already started across North Wales through the PSBs in particular. So once more, there is work for us to do, but like everything else, we are stronger together. And if we work together, I see excellent opportunities with the third sector, with the local authorities, and also with our societies that are already ahead of us at times, and our communities. This is a big task for Rod, but I think good work has started. It's important work that will be a part of the agenda. So thank you very much to Rod that this is a priority and that the work is ongoing.
Yep, Tracy. So we're looking to the plan in January 22 then, Rod.
Absolutely. The plan will be available as a draft. We will also, to Teresa's points, will engage with the regional approach to decarbonisation, because there are a number of work streams that are being looking at. IT is one, transport is another, vehicles and corporate office hubs. So the importance of having our high-level draft plan costed by Christmas is one that we will be able to share with our partners as we play a role around decarbonisation across the North Wales region.
Okay, and then Rod, just tell me one thing. I know we discussed at the workshop an additional organisational value, and it's referenced in the paper. I can't remember where we got to in determining whether that we were going to agree to that. Have we reached, as the executive team, reached a decision yet? And if not, when are we going to pick it up?
In terms of executive lead, Chairman?
No, sorry. The paper refers to, we considered an additional organisational value protecting our children's future. I can't remember, Rod, now where we got to in that discussion and whether we agreed it or it's to be agreed.
We discussed it, it's to be agreed, and what we will need to do is to refresh that within the organisational values basically from the output of the board development session, because I think what the board development session identified is a gap in our values about the environment.
Yeah, okay. Thank you. Sue, I think you're going to come in, and I guess around stronger together as well in a relationship to that.
Yes, thanks, Chair. So Rod and yourself are both right. That was a suggestion at the board workshop. That has also been taken through the Stronger Together discovery. So clearly, whilst our values are absolutely true, we have engaged with the organisation around whether our values are still true, whether they're still felt to be relevant and pertinent, whether they're owned in the organisation, whether people see them as lived and experience them as a lived experience. So that piece of work and the suggestion around an additional value has been integrated and will be integrated into the Stronger Together co-design work. Just wanted to be sure that there wasn't a perception that the board are going to decide on this in isolation. Clearly, the board is committed to using discovery to inform our values moving forward, and that's the timescale and the process we're following.
Thanks, Sue. Thank you. So the board is asked to note the publication of the NHS Strategic Delivery Plan, note the appointment of the Carbon Trust to support the Health Board, and to support the establishment of the Sustainability and Decarbonisation Programme Board, led by the Executive Director of Finance. Are you happy to note and support those three things?
Yes.
Yeah.
Yes.
Okay, Rod, thank you for that. So we're going to move on into the quality, safety and performance, i.e. the present section of the agenda. And the next item is also with you, Rob, and you, Rod, which is around residential accommodation. Again, Rod, please recognise that I certainly have, and I'm sure everybody else has read the paper and considered the content. So over to you to highlight what you wish.
Thank you, Chairman. So yeah, on the understanding that everybody's read the paper, I think the key point to bring out is that we are moving away from seeking a solution in terms of capital to moving to a managed service model. The paper sets out the background, it sets out the discussions that we've had with Welsh Government around the availability of capital, and also then the rationale in terms of why we're now moving forward with a managed service model. Again, we have some significant challenges with the residential accommodation. Again, picking up some of the discussions that have been on the agenda for today, one of our key challenges for the future is about, in terms of our offer to staff, affordable and suitable accommodation. And in regards to recruitment and tension, this is a key part. And clearly the estate we have will not enable the board to deliver that solution in the future. So the paper sets out the direction, sets out the programme. Chairman, I'm quite happy to take any specific questions.
So I'll go to John first. And I'm conscious of the fact John chairs Finance Performance Committee that have received this paper before we have. So, John?
Thanks. It's not a specific question, just I wanted to support it on the basis that, no, I think we're all aware of the poor condition of our residential estate. And when we discussed this at F&P, we supported this approach to actually try and move this forward and make some improvements to. And as you say, Rod, it's a key part of that recruitment and retention element that we know is a challenge across the whole board.
Thanks, John. So I won't repeat anything that you two have said. I'll go straight to the fact that the board is asked to approve the procurement proposal and to note the continued opportunities to work collaboratively with local social housing providers. Are the board happy to do both of those things?
Yes.
Yes.
Yeah.
Jockers out. Okay, thank you, Rod.
Jockers out.
In here, and thanks for the work with your teams on those papers. And thanks, Rob, to you too. Jockers out, who will? So we'll move on then to the committee and advisory group chairs assurance reports. We have two, first of all, from QSC, Lucy. So over to you. So anything you want to highlight?
Thank you very much, Chair. So I'll take both reports at once if that assists, because we had a number of matters of substance to discuss, and the committee also held a workshop in August to explore assurance and improve the quality of reporting as well. So we discussed the vascular service in both meetings, and the committee were concerned about the lack of progress in terms of progressing the areas for development. It was helpful to receive the detail around what services are delivered at each site, as this has clearly been cause for confusion. But the committee have reiterated that any change from the original commitments needs to be very clearly articulated to our public and our stakeholders, along with the reasons for any deviation from the original commitments. Of course, Nick has now joined us and was very upfront with the committee in September in not being able to provide assurance at this point due to the need to review the action plan again. So he's going to be leading the oversight group, but evidence-based assurance is needed, and the committee were clear on that in the future to ensure we are in a position to be assured over this service, because we've had several reports of this nature, and going back to the previous step when we've had a change in leadership. So, but Nick is very much aware of that. The committee is expecting to receive a number of external investigation reports at the next meeting, including the concerns raised about Llandudno Hospital and the tragic suicide of an inpatient in Hurgust. And on that note and others, the committee also remains concerned about the service being able to evidence learning from never events. We received a thematic report on this at the July meeting, which identified a number of recurrent issues. So that conversation then triggered some of the conversations that we then had in the workshop around learning and assurance. And the outputs of that workshop will be followed up, but these are areas that need to be addressed as a priority. As you can see, the committee have recommended that the board consider a quality and safety deep dive for a future board workshop to facilitate moving that forward. Following concerns about the urology service, both internal and via the Ombudsman, The committee also supported a number of recommendations, including commissioning a Royal College review and establishing an improvement group to start improvement works that are needed in the meantime. The college review is going to take some time, of course, and so we're keen that in the meantime, what needs to be done to make the service as safe and efficient as possible is still progressed, that we're not waiting for that Royal College review. The terms of reference has been discussed, and I think it's very near to being approved, so that it can be started as soon as possible. And the Royal College are aware as well, so they're anticipating that referral. My final point, I'm sure Jill will want to come in, but my final point that I wanted to highlight was the exception report that the committee received this month on the progress to reduce the risk from ligature incidents across the Health Board. And we received a comprehensive report from the division about this piece of work, explaining the difference between the previous risk assessment work that's been undertaken based upon the guidance and focus at that point in time compared to the work that's now being undertaken. So previously it was focused very much on the high ligature points, whereas the programme that now is going on across Wales, it's not just here, is focused on the low ligature and anchor points across the estate. And it was those areas that were present in the recent inpatient suicides in both the Ablett and the Herbis unit. So the committee will be receiving assurance over the completion of that programme in the future as well. I don't know if Jill or Teresa would like to add anything to that. Thanks.
Chairman, if I may just add to the point around the ligature, that piece of work is being extended across the Health Board and will be work undertaken in conjunction with our health and safety colleagues, as well as obviously staff within the clinical divisions. So it's just to let you know that we're not only taking that across mental health, but across the whole of the Health Board.
Thanks, Jill. So, and thanks for the comprehensive update, Lucy. In terms of urology, Jill, Joe, can we confirm shortly that the terms of reference have been finally agreed, and can we have an update on the commissioning of the review at the next board meeting, if not before, please?
Yes, you can. We're just finalising those. They will be sent round hopefully later today, Mark, if not early tomorrow, so that we may finalise them. And we will be then submitting them to the Royal College. So happy to give you an update and work around the initial improvement group, and the formation of that has already commenced alongside some recruitment for additional urology consultants.
Thank you. In terms of vascular, Lucy, we've got an update on the agenda, so I'll leave Nick to cover the observations you've made under that item and to assist us to understand what his response is going to be with the team. In terms of your report, Lucy, there's one item to be referred to another committee, so I assume you and Medwin as Chair of Audit are facilitating that. And then the matter requiring escalation is around the learning, and the board could consider quality and safety deep dive discussions in future workshops. I'm not going to put that out for agreement because I just think that's sensible. But can you then, as Chair of QSE and Jill, arrange that, please?
Yes, of course. Yes, I've already discussed it with Louise as board secretary, but yes, we'll take that forward. And yes, I have confirmed with Medwin about the referral over to Audit Committee.
Thank you. Thanks, Lucy. Finance and Performance Committee, John, anything from your good self?
Thanks, Bart. Obviously, I'll take the paper as read. And we've covered some aspects within there, and some of the financial stuff we'll cover a little bit later, but probably just worth highlighting. We're still in a break-even position. There were some concerns around savings, but we're assured that's going to be delivered according to plan. Capital spend's on track as to where we expect it to be, but the key risks that came out were things like planned care delays, the ongoing recruitment and retention of staff issues we've had for a long time, the robotic surgery delays, and medically fit for discharge patients which we know are causing problems with the patient flow around ED and the rest of our services. I'll leave it there to keep it short and sweet.
Thanks, John. Jill, Nick, robotic surgery that John has just highlighted. I've lost track of that. There's keen interest in it. No idea where we.
Yeah, Joe may wish to come in on this, but I think the contract award is being made, Chairman, so we will be able to progress with implementation on that. I am suggesting that the implementation and oversight of that is included within the improvement group for urology.
Thanks, Jill. Understood. Okay, thanks, John. So move on to Remuneration Committee, which I chair. The report is there. I have nothing to add in terms of the report. Any questions I'm happy to receive now or outside. Next is the Local Partnership Forum. Sue.
Thanks, Chair. So nothing more to add other than those things that are in the key advice feedback to the board from that meeting, but happy to take any questions.
Can I raise one issue that's referenced to, and that is around delays in the translation of papers for job vacancies and recruitment?
Yeah.
Is that being addressed?
Yes, we've been working really closely with the Welsh language team. We've identified and recruited some additional resource for them and with them. So, and we're seeing an improvement in delays. I think we'll continue to see improvement, but it's also built into the recruitment process improvement review that's being done collaboratively with key stakeholders from across the organisation. So we'll continue to try and work with the team to improve the timescales.
Okay, and I'm sure the board have noted the feedback for the board in the report. So, and there are 6 items listed there. So I've certainly noted them, but I am assuming, Sue, that those things that need to be being progressed are being progressed in response to the concerns and observations that have been made.
Yes, absolutely. The vast majority of them have already been resolved, particularly increased use of recording and the pharmacy recruitment piece of work. We progressed that immediately after the meeting, and they're both well underway.
Thanks, Sue. So we then come on to the SPPH report, which is with Lynn.
Thank you. You'll see from the beginning of the report that we do cover an awful lot of business, and it's a very broad breadth. The key assurances we received were to do with the Welsh language annual report, which we were absolutely delighted with, which we'll be discussing later on. And we were also very pleased to hear about the development of the North Wales Medical and Health Sciences School. The key risks, similar to other committees, so these are constant threads and trends throughout. One being the recruitment featured as an issue in a lot of the reports that we received. And I do know that Sue is carrying out a review of recruitment, which no doubt will be reported upon as soon as it's available. We also talked about the risk of planned care, and we were very fortunate that Jo was there, so she was able to add a lot more to the context of the risk there. And finally, similar to QSC and other parts of the reports of this paper, we do need to see primary care access and a more strategic approach, and hopefully that will come through in the next period. Thank you.
Lynn. And Sue, just to confirm, we've got a workshop coming up, particularly to focus a substantial part of it on your good area of responsibility, sitting around recruitment, retention and welfare.
Yes, 7th of October. We're on with the planning.
Good, thank you. That's assuring. Thanks, Lynn. So they are the Chair's assurance reports that I have in front of me, and we now move on to the quality and performance report. Jill, I'll leave you and Nick to introduce this. Again, I'm conscious of the fact we will have read the report and it's also been through Finance Performance Committee. So once you've done your introduction, if you like, I'll ask John if there are any comments he wants to make on behalf of Finance Performance before I open it up.
happy to do that, and I'm sure Nick will support. I think principally, Mark, there are a number of areas to highlight within the report, many of which have been discussed within the board already today, including unscheduled care and our approach to planned care, and indeed infection control. So I am happy, given that this has gone through an F&P and other has been scrutinised considerably, to go straight to questioning, but I know that Nick wants to pick up one particular element. So if I can hand over to him in the first instance.
Sure. Nick, over to you.
Thank you, Chair. It was really just to highlight under the agency spend and the mortality area in particular, where I think the agency spend, we need to consider that as part of our quality, the way we deliver quality clinical services, not just in terms of finance, important though that is. And we have established with Sue and Jill and myself a weekly meeting to look at medical resourcing in order to be able to address that, recognising, of course, we've already heard that our workforce are absolutely tired, so therefore a dependency on agency locums, particularly agency doctors, is inevitable. Around the mortality, because there's been some media attention to this recently, just to provide an assurance that there is a huge amount of work happening in order to provide greater clarity around this. We need to be able to benchmark ourselves against other NHS organisations in order that we can really understand where any mortality issues may lie and embed learning from our mortality reviews. That's work I've picked up in the last couple of weeks. I don't think it'll be finalised by next month, but we hope fairly soon to be able to prove that cycle of learning from our mortality reviews and really being able to target our interventions. And very lastly, if I may, around sepsis, I think there are some data issues there which we need to recognise, but we need to take it very seriously, because for me, the quality of recording of data is arguably a proxy marker for the way our clinical notes and the other quality aspects of our care are delivered. So absolutely no room for complacency. And happy to take any questions on those points, but I just wanted to add that to the highlight report that you've seen. Thank you.
Thanks, Nick. Nicola.
Thanks, Nick. I'm absolutely delighted to hear about your weekly meetings to explore the quality of the service from an agency perspective. Just to join up, if from those meetings you surface any training needs, please do get in touch with me, because that's something that we could explore.
Thank you.
Jill, the substantive area that we've probably not covered in this agenda to this point, albeit we've referenced the dialogue with Welsh Government around the DTCs, RTCs, is the one of planned care. So, and there is, of course, an update in the report. Anything you want to highlight in terms of what we're doing around the planned care challenge?
Yes, thank you, Mark. So there's a lot of work being undertaken around planned care, and we alluded to the RTC longer term solution. We have commissioned outsourcing work with the private sector, and we are using our green sites as much as possible. What we are doing, though, via our executive incident management team on a weekly basis, is ensuring that we are prioritising our planned care. This has been deeply distressing for the staff involved, because it has meant that we are again cancelling planned care levels that we would not normally anticipate. And obviously it's deeply distressing for those patients who are being cancelled and are waiting still longer for their planned procedures. But there is work in place in terms of insourcing capacity and, as I say, accessing private sector, as well as using as much of our own capacity as we can, cognizant of the unscheduled care pressures that we have, whilst we do the work that is required to ensure that our RTCs make progress at pace.
Thanks, Jill. So, John, over to you as Chair of Finance and Performance.
Thanks, Mark. I think from a finance performance point of view, most of the issues that we covered I've summarised in the Chair's report, but no, it's worth noting that there were some improvements in performance around cancer, vaccination rates and things. There were a number of areas where there'd been a clear detriment in terms of performance, but those were being addressed. And I think highlighted that stroke had something like a 3 months delay in terms of the programme. In terms of the report we've got in front of us now, one of the things I hadn't picked up before, but I had a specific question on now, which is on the bottom of page 2. It talks about a massive increase in terms of psychological therapies. And I just wondered now whether that was a real increase in performance, or is it due to a waiting list initiative, and can it be sustained in the long term?
Okay, Jill, I'm not. Tracer is best placed to answer that, is it? Jill, sorry, Tracer. Apologies, Tracer.
Iawn, John, am y cwestiwn. Meddwl bod ni'n gweld
Thank you for the question. I think we are seeing an increase in the waiting list initiative, but moving things forward. There has been work in relation to psychology for some time, and very grateful to the team who've been working very hard to increase those figures. And I do feel that this is real work that is happening within the team that we already have. To reach these targets, you will see some of the narrative in the paperwork, but hopefully we will continue to see progress. And I'm very grateful to Beth Parry-Jones for working in moving this agenda forward, but also in relation to the departments, we've seen increase in numbers.
Yep. Teresa, Cheryl.
Thanks very much, Chair. Yes, just to highlight the performance in CAMS for children awaiting the neurodevelopmental assessments. It still remains very poor, but it is up slightly. But we're hoping that the new initiatives that we've got in place are going to lead to a real increase in this, and therefore much better outcomes for our children who are currently waiting. Thanks, Chair.
Thanks, Cheryl. Jill, there's reference in here to letters going out to planned care patients and the response rate, I think, being at 6%. I assume that we're doing our best to encourage a higher response rate, and that, which no doubt has gone up since that was reported. Is that correct?
Yes, it is. I can't give you the number off top of my head, Chair. Apologies for that, but that is being monitored and followed through.
Thanks, Jill. So, okay, I'll bring that item to a close now. And as John properly highlighted, there are some performance improvements detailed in the report, and we ought to acknowledge that as the board. And we've received substantive updates on unscheduled care and planned care, and that will continue. So thanks everyone for your engagement on that item. We'll now move on to the operational plan and monitoring report, and Rob.
Okay. Just briefly, I obviously assume everyone's been through the report. Just to highlight some of the emerging themes that are coming through in terms of non-delivery. There's three specific areas: the staffing, and that's availability of workforce, and problems with recruitment, which I think we've mentioned previously. General slippage on timescales, some of which are outside the control of the health board, for example, around procurement. So that's delayed the implementation of some of the schemes, but also around business cases, and we've got improved guidance on business case development is being progressed by programme leads. Going forward, the planning process is being revised to enable a lighter touch and sure delivery, reducing some of the bureaucracy really. And finally, in terms of the report format itself, there's a need to clearly demonstrate the actions being undertaken to improve those schemes that are off track. And I think going forward, we need to be clearer on what are the actions that are being undertaken against the schemes, in particular the red schemes. Thank you.
Thanks, Rob. John, did you want to come in first?
Thanks, Mark. If I can get my video to work. I just really, no specific question at the moment. I just want to acknowledge the improvement in the report from this version, from what we saw at F&P. Obviously, it's moved on a little bit, and I think some of the comments that were passed on have been incorporated in this, and I think it it just helps its readability and usability as we go forward. So I just want to say thanks for that, Rob.
Thanks, John. Lucy.
Thanks. So my comment may not go down very well now, but I'm glad you referred, Rob, to the format of the report needing to be improved, because the purpose of this report is to provide progress so that we can see progress against the programme level priority actions that underpin the delivery of the plan. But it doesn't do that. As an example, on page 8, the programme creation of a digital strategy has 2 target dates, with one showing as completed and the other one on target. But I have no idea what action has been completed and what action is still on target. It's just not there. That's just an example. It's that there are many others throughout the report, and I have repeatedly raised this problem with this report, and I thought it had been agreed that the report would not be presented in this format again for this financial year. So it's really disappointing to me to see that we're still, there's more emphasis there on who the executive lead is than actually what the actions are. And I just get no assurance at all from this report. I'm sorry.
Yeah, I agree. I think the focus of the report needs to be on the actions, the actions that are being undertaken. I acknowledge that, and it's not clear enough. And if it doesn't provide the assurance, then we'll need to address it going forward.
Sue, did you want to come in?
Yeah, thanks, Chair. I was going to highlight a couple of pieces of progress, but I think it's worth kind of just picking up on that point a little bit, and maybe in support of Rob. So one of the things that we clearly needed to do was to conclude this reporting cycle, and these reports have been through the committees and therefore needed to have been presented at the board in the same format. Absolutely, it has been recognised, and we have listened to the feedback from both independent members and execs, and Sue and Rob and team are collating that, working with the performance team to bring the revised format reporting back to the board. I think it's also worthy of note that Rob mentioned the planning processes and the process to bring this report together, and that is something that is subject to quite a bit of feedback from discovery. So I think there's real opportunities for us to co-design the planning process, B, the plans, and then absolutely the best way of representing those things. Bearing in mind this is the performance up until June, so there is a bit of a lag there, but just wanted to make sure we're clear that this is concluding the committee cycle. I just also wanted to highlight a couple of things. I mean, clearly this is close to my heart, but it's also close to everybody else's heart. It's not owned by me, and that's the strategic organisational development work that we have all committed a tremendous amount of time to. That has progressed and is progressing fantastically well. We are well in line with the target numbers of people being engaged. Actually, it's gone above and beyond that in terms of continual engagement. And I'm just mindful this report is up until June and therefore doesn't reflect that. And I think it's important, given vast majority of staff have committed time and energy to engaging with us on that's noted. I think the other thing I would want to highlight, the board received the annual health and safety report at the last meeting in July, and no doubt had discussion around the investment, both resourcing and commitment that was required to bring health and safety on. I'm pleased to confirm that has been secured, and we're now motoring ahead to really secure the improvement that we need around health and safety. So I would anticipate the next round of this report showing a very different picture. I just wanted to add that. Thank you.
That's helpful. See, John?
Yeah, thanks, Mark. I just wanted to come back and support what Lucy said to an extent as well. My initial comments were there have been improvements to the report. I recognise what Sue's saying, that we need some co-design maybe to go forward, but there are still gaps in this clearly in terms of clarity of what each target is. What are the sub-actions against an area that we're trying to understand in terms of its progress. So there is obviously more work to be done, but I look forward to that process to try and improve it. But we do need to move that forward as quickly as we can, I think.
Right. So this is the plan and the plan monitoring report, with primary responsibility resting with SPPH committee in that regard. Rob, can I ask that you work out how you can engage with Linda and John as chair of F&P on that piece of co-production to try and get this matter resolved once and for all? It's not helped, of course, by the fact there are differing opinions, but nevertheless, we need to crack this once and for all, particularly the point around we've got dates, but no sense of what those dates relate to in some parts of the report. Elsewhere, that is more obvious because it's recorded. So I think we need to resolve this once and for all. That's my first point. Second point is, Rob, and I'm not sure you're aware of this, Joe is, I've been in an exchange with Sue this week.
Yeah.
There's no right answer to this, is there? But this report is essentially the report that went to committees. The problem with it in terms of board is, of course, by the time it gets here, it's end of June. It's been through 2 committees, and some of the actions listed in here are old, to say the least. And by the time they return to board after this meeting, it's another 2 months. I think we need to consider whether we continue with the same report coming through to board, or we provide an updated report for board which reflects more closely where we are in terms of time, the date, etc. As I say, there's no right answer to that, but I do think we need to examine it, given this report highlights that fact very well.
I spoke to Sue about it yesterday, and it is around the version control, so we'll pick that up as an action as well.
Thank you. Right, so with all that said, I'm going to move us on from that item, and we're on to the finance reports, Rob. So should we focus on month 5 as we would normally? The most recent report?
Yes, thank you. I just assumed we'd go straight to month 5. So just want to just to highlight a couple of things, really. First of all, we submitted a revised financial plan to Welsh Government in June. Within it, we forecast a balanced position for the year, and our year-to-date position reflects that. We've got some key themes, though, and what I'd like to highlight around the challenges for the rest of the year. Savings delivery, I think it was mentioned by John earlier on. We've got 17 million targets. We've got delivery of 12.1 million and additional schemes in the pipeline. And we're having discussions with divisions around further opportunities to ensure we deliver the full value of the plan. The real issue with the savings, though, is we've got, of the 12 million we've identified this year, 7.4 is recurrent, so there's a significant delivery of non-recurrent savings this year. So going forward, we need to align our savings requirement with the transformation programme and start to deliver recurrent savings going forward, because that could just, whilst we'll be delivering savings this year and maintain our balanced position, it could create it will create a bigger challenge for next year. There's also the strategic support funding and plan care recovery monies. We've mentioned that around plan care. As part of our month 6, we'll be reviewing the planning assumptions behind those schemes and looking at alternatives. We'll be taking that through executives just to ensure that we get maximum value out of the additional funding that we've received. So happy to take any questions.
John.
Thanks, Mark. Again, if I can get my video to start. I think, Rob, you're right to highlight the savings side of things, that non-recurrent element is a worrying aspect as we go forward. I think one of the thoughts I've been having is that if we go back 2 years, we built a process which was defining a pipeline of savings, and it feels like we've lost that to an extent, or it's not being presented. And I just wonder whether we need to start now in terms of that pipeline of savings, not just for this year, but to actually go forward in the next 3 years. If we're going to go to an IMTP process starting from March next year, we need to be clear within that what is the pipeline of savings over that three-year plan. But where are we in terms of developing that pipeline process and looking further ahead than just this financial year?
I see Joe's put her hand up. I presume Joe would like to answer that.
Yeah, I come to it, but I think John's on the money, Rob, isn't he? In the sense of, we won't be able to set an IMTP and see it approved without being clear about what the savings pipeline is for the next 3 years and how we're going to break even.
Yeah.
So that's becoming ever more crucial, isn't it, as we approach the autumn of this year and start to arrive at an IMTP.
Yeah, it's going to be the challenge for next year because of the ongoing impact of COVID, the fact that our spend has increased just because COVID has not gone away, coupled with the fact that the challenge for the actual operational services to deliver savings because they're already sort of working so hard to deliver COVID. It's a real challenge that we need to give some time for next year.
Yeah, okay. Thank you. Joe?
Thank you. John, you're absolutely right. We need to be able to work within our financial envelopes. And when the chair and I spoke with the Minister and the Director General with regard to regional treatment centres, the Director General was very keen to remind us about a discipline to break even. He also talked about the potential to move to a longer term planning cycle. And I quote, the board must be both disciplined, but cannot allow a short-term financial focus to get in the way of the need for ongoing strategic investment. So I think what he's saying to us is we need to be able to do two things together. One is, as John has suggested, to make sure that we are through service transformation and by considering variation and unwarranted variations in clinical care over time, we increase our efficiency and lower our price point. That will enable us to become a more efficient organisation and to live within our means. So our pipeline of savings you'll start to see will be much more expressed around reduction in low value care, reduction in unwarranted clinical variation delivered to us by service transformation, whilst we continue with the good practice housekeeping tasks around ensuring that we're working on best value across our support services. So yes, we need to continue our focus on break even, and we need to do that in a way that engages our clinical colleagues so they can work with us to maximise the effectiveness of our spend. Thank you.
Thanks, Joe. I think the other thing we need to be aware of, Rob, is at the last meeting with the Minister, the Minister asked chairs to consider whether, if more funding becomes available through the settlement this year, whether we've got schemes ready that will enable us to address some of the challenges, and if so, what those schemes were and how much they will require. So I just think we've got to keep on top of the on-the-shelf schemes that we might have or configure with that in mind.
Yeah, and there's, as part of, we've started the planning process for next year, and part of that will be identifying what the planned care challenge will be next year, and making sure that we've got a wider menu of options. Our capacity internally is limited, our capacity externally around outsourcing is challenged because we're fishing in the same pool as England colleagues, but I think the sooner we start those conversations, the better.
Okay, thank you. Rob, John, did you want to come back in?
Yes, please, if I can. There was just a couple of things from what Joe and Rob's just said. One, in terms of our planning process, I'd be wanting to see that we're looking further ahead than just next year. You know, our planning process should be looking 3 years ahead or even 5 or 10 years ahead. And in terms of the savings, I recognise that this is linked to our transformation, absolutely. But I think what I'm looking for is assurance that there's a process around it that clearly documents as a funnel type approach in terms of, you know, these are the ideas for savings that we're going to deliver through. And as you build the detail and get more clarity around what an activity will deliver in terms of savings, we can have more confidence in its savings. So it's what is the process and how do we get visibility that process is working is suppose what I'm asking around that side.
Joe, then Chris.
Thank you. Yes, we are moving towards a 3-year planning cycle, subject to confirmation through Welsh Government, but that is very different. I think we are seized, and our colleagues in Welsh Government are seized of the need to be more longer term. There will always be some accounting requirements to manage from year to year. I know you, John, you understand that. Very comfortable with the funnel document, the funnel diagram approach. The discussions with regard to identifying those potential savings for future years from a value-based care point of view have already commenced as part of the planning process that Rob has talked about. Let us think and come back to you, Mark, offline about the best way of involving or informing IMs of those processes, probably through the F&P process, but just let us think about how we might respond most helpfully to John's question. Thank you.
Okay, thanks, Joe. Chris?
Thank you, Chair, but Joe's just made the point I was going to.
Okay, all right, thank you very much. So, Rob, thanks for the report, which we note, and I'm going to move us on to Pedro Point Sci, the Vascular Steering Group update from Nick.
Sure, thank you, Chair. Perhaps teasing out some of the key issues from the report that we all will have read, but also responding to Lucy's points made earlier. Firstly, there is no intention at all to change the service model that's currently being agreed, although clearly we do need to continue to keep a very close eye on the enactment of that service and any changes that might be needed. For me, this is a really, really important area. It's important because of the quality that we provide to our patients and the patient experience. It's important also, and I think sometimes we may have forgotten this, it's important because we need to support our staff who are in a service that's been under an incredible amount of pressure and scrutiny, quite rightly, but there's been an impact on the staff. And also, as Lucy pointed out earlier, I think there are lessons to be learned as we make service changes across the health board, particularly when we work across the 3 acute sites, as to how we can ensure that service is provided safely and there are no difficulties when a service is changed. As Lucy pointed out, I wasn't happy to bring the current action plan to QSE last month because I think a significant amount of work is needed. That work is to make absolutely clear what each action means, who the action owner is, and where there isn't a rapid time frame for completion, what mitigations are in place to ensure patient safety, quality, and experience in the meantime. And with the appointment of a new, albeit interim, network manager, the first draft of that revised action plan, I hope to bring to QSE next month. We will also make absolutely sure that nothing is lost from the previous action plan and be mapping actions across. I think it's fair to say also that there will be new actions, because there are some issues I think that the service recognises need to be addressed, which haven't previously been reflected within the action plan. In the vascular steering group, I think we've adopted this month some changes in the way that we'll be reporting henceforth. That includes escalation of any times that we don't follow the service model, and so we can be clear why that didn't happen and whether any changes indeed needs to result. We'll be looking very clearly at our establishment and our medical workforce and nursing workforce issues to ensure that we really understand where we are in terms of recruitment and ensuring that we have the right workforce in both the hub and the two spoke sites. And we need to have more consistency of reporting around our quality issues, around safety and around any clinical incidents that may occur. So that standardization of reporting at the vascular steering group, I think, will start to give the clarity of where issues lie. Lastly, before taking any questions, you'll see in the paper that we've established a vascular oversight group. That's a fortnightly meeting, and the team that are really driving all this work and working incredibly hard, meeting in a fairly informal meeting, but just to ensure that grip and pace in delivering the action plan, which is something which the larger monthly vascular steering group I don't think can realistically do. And that'll ensure that we can rapidly respond to any delays that may occur. So with the paper that I'm sure everybody's read, I hope, Chair, that gives an update on where we are, but very happy to take any questions.
Before I come to Lucy, Nick, can I just explore a comment made in the paper, and that is that the action plan, which began the 6th of September, is going to require significantly more work, as its current state is not acceptable, in order to provide clear assurance on progress made and clarity on the mitigations. That's, to me, a very concerning statement, given what we thought was the amount of work that had gone into that action plan in the first place, and the fact that it was being led. Can you explain why you have come to that conclusion and what the effect of that is?
Yes, of course, Chair. Thank you. So it may well be that all the actions are taking place and people are working in exactly the way that they should be. But I think others in the board today will also have recognised this, that the clarity with which the actions were expressed weren't always clear. The action plan wasn't completely up to date, and I think it wasn't always clear exactly who that action owner was. We're now working through each and every one with the action owners to see where there are gaps, and whether those gaps are of any significance in order to be able to provide the assurance that the board rightly sees. It's work in progress, Chair, so I can't really dive down into the further detail and whether the concerns that you rightly express reflect an actual issue or whether it's just a presentational issue. But clearly that will be something we'll be feeding back to next QSE and of course the board.
And then secondly from me, before I come to Lucy, there's a statement, Nick. Similarly, the acute director of the hub site would ensure that the hub and spoke arrangements are properly implemented and liaison with the other two acute sites and area teams where appropriate. Given our inability to do that seemingly to this point, that's quite a significant challenge, I would have thought. So is it within the gift of the acute director to resolve that particular issue that has been sitting as a problem for some time now, I would assume?
It has been sitting there for some time, and I don't think, certainly but I don't think the board has absolute clarity of where the issues have arisen, why they've arisen, and when they've arisen. I don't think it would be fair to hold the hub acute site director solely accountable for that. And that's part of the reason for that vascular oversight group, that live meeting, if you like, taking place every fortnight, so we can rapidly understand where the issues are, and the escalation exception reporting to vascular steering group being carried out in a realistic way. I think sometimes it's the hub pulling inappropriately in from the spokes, and sometimes perhaps it's the spoke pushing inappropriately into the hub. And we really need to get to grips with why that's happening and the reasons for it. And it may well be related to the establishment of the staffing in each of those sites.
Okay, so I'll go to Jill and Joe because their hands have gone up since I made those observations, and then I'll come to Lucy. So Jill first, then Joe.
Thank you, Chair. Just to support some of the points that Nick was making there. So one of the things that we are doing is ensuring that where there are blockages in patients being managed in their local sites, we are pulling those out at the site meetings now to ensure that we've got an oversight and are managing those movements appropriately. But so it is a shared responsibility, picking up Nick's point. It can't just rest with the hub, because very often, and this has been exacerbated by some of our unscheduled care pressures, the transfer of patients across site has been difficult. So it is working collaboratively, and we are picking that up via the site meetings now to ensure that we can intervene where possible.
Thanks, Jill. Joe.
It's about getting the balance right, isn't it, between clarity of accountability, support for colleagues to be able, and support for colleagues to be able to deliver. So I want there to be absolute clarity around the responsibilities that the YGC has to the network as a whole. And I want to be clear the responsibilities that the other site managers have with regard to the provision of clinically appropriate services on each of their sites. So it isn't about saying to the YGC site manager, it's all on you, but it is about being clear about the fact that this is a network solution. There is a hub site, there are spoke sites, and each of those acute directors have particular responsibilities. And it's only by working together and being stronger together will we ensure that we can get to where we need to get to as quickly as possible. So it is about being clearer, but it isn't about from as an executive point of view in any way, shape or form, thinking that those individuals won't need support from across the system to do what our patients need us to do with regard to this service area. Thank you.
Thanks, Joe. Thanks for your patience, Lucy. You next.
Thanks, Chair. No problem at all. I think that was helpful follow-up from Jill and Joe. So I just wanted really to picking up on some of the update there that Nick provided to us. There's been concern, as you know, from our public and patients relating to the vascular services now for quite some time. And there is a perception that every time there is a change in leadership for this area, that we take a step back again. And I think that's because QSE committee and the board have been receiving reassurance on this issue rather than assurance. And I mean, Nick, we had this discussion at QSE, so I know you get this. And of course, you're new to it as well. But if we are going to give the public and our patients confidence in this service, we really do need to be providing them with evidence-based assurance instead of getting an action plan each time with progress and then being told, well, actually, that progress wasn't really the right progress, or that action wasn't clear enough, and we need to kind of go back and look at it again, because we've been here a number of times now. We need to start turning this into evidence-based progress so that we can be absolutely clear on who is responsible for what is being done, and that we see pace over this progress as well, because that's another area the committee have been concerned about for some time.
if I can come back, Lucy, I absolutely understand what you're saying, and of course, it's very difficult for me to respond adequately because I think the very need that we need to revisit the action plan and make sure that it is evidence-based and that it is right. You've been told this before, and I'm telling you it again. I guess it's for QSE to hold me and the team to account for actually ensuring there's pace on this. But I don't think we, at the last month's meeting, of course, you didn't see the pace and the change of delivery that you rightly expected. In fact, you saw a pause while we revisited. So I absolutely understand what you're saying. Further, I suppose, and in the paper, it's quite clear that we are anticipating the second stage of the college review, which is likely to arrive probably in the first week in October now. And of course, that may, again, cause us to rethink what we're doing, why we're doing it, and how we're doing it, and might result in a further redesign of the action plans and the progress we need to make. But that, of course, will be much clearer within a couple of weeks.
Okay, so Lucy's points are well made. Thanks for the response, Nick. As our new medical director, we look forward to seeking that assurance from you as you get your feet under the table and unpick where we are with the action plan and so on and so forth. So I look forward to receiving an update in that regard via QSC committee for next time. And if there's a problem that arises in the interim, then I'd expect it to be escalated to Joe and I. So I look forward to proceeding on that basis, Nick.
Of course, Chair.
Thank you. Right, I'm going to move us off of that item then onto the Ysbyty Gwynedd COVID-19 outbreak review report. Jill.
Thank you, Chairman. And before I start, I'd just like to reflect that this report has gone through QSE and was subject to quite considerable discussion there. I think the points I would like to raise within the report fall towards the end in terms of the work that is continuing to ensure we're making our premises as infection control proof as we can be, albeit that we recognise, and it is called out in the report, that our staff are suffering fatigue, and we do recognise that is inevitably having an impact. The Safe Clean Care programme is being maintained, and it is ensuring that we are beginning to embed some of the changes and we're getting better medical representation within that group. The points I want to pull out particularly are the balance that we're having to take between assurance audits around IPC and that fatigue that staff are demonstrating. And we are working with informatics informatics colleagues to see what we can put in place that could mitigate against the amount of work that's being undertaken, not only with those audits, but ensuring that we've got patients in the right bed, the right times, and we can monitor the movements. So that continues to be an ongoing conversation, which Chris and the teams are supporting me with, but it's also impacting our unscheduled care improvement programme. I've already called out the unscheduled care pressures are continuing to add a level of concern, and that is being dynamically assessed. I would say day by day, Chairman, but I would say it's hour by hour, and most specifically the workforce gaps that we're seeing. We are closing those gaps in domestic services and elsewhere, but they do remain a challenge, and the recruitment is ongoing. We're constantly out to advert for those areas. And as I say, the interdependence between the Stronger Together and the unscheduled care programme has been recognised, and we are working to ensure that there is minimal duplication and that we're working smartly across those pieces. Going back to the report that Hilda Williams provided for us, as you know, she's an external resource not known to the Health Board who undertook that review of YG. The outbreak at the request of the board. The report is here in full. and the response to the lessons learned, the immediate lessons learned having received the report, is included within one of the appendices. What I would say is that is now, since this report was initially written, where there are gaps in those assurance processes, they're already being embedded within the Safe Clean Care programme. And I would like to reiterate this was picked up at the QSC, but happy to take questions. Mark?
We've been having a few glitches on with IT in Carlton Court this morning, which is why I was a little late. Oh, here he is.
I'm back. Sorry. So I did lose you a bit, Jill, there. So are there any questions? Is that the point we're at, Jill?
It was, Mark, and as I just outlined the fact that we have responded to the recommendations made within Hilda's report, and they are being embedded within the Safe Clean Care programme moving forward.
Okay, any questions or observations? No? Okay, so first thing I would say, Jill, is this is to my mind at least, a much better report. I do think it's fit for purpose, which is why it's here today as opposed to last time. And I think it more thoroughly and comprehensively addresses the terms of reference. As you say, there are a number of recommendations highlighted. My only query, Jill, was in terms of the actions, there's no sense of timeline or clarity about who's leading on what, but I'll leave that to you because that's a matter for you as the lead executive with Deborah to address. But we look forward to hearing of progress in terms of addressing the recommendations and also the learning to be implemented to ensure that, as far as possible at least, we seek to minimise the likelihood of further outbreaks appearing across our health board.
So just to confirm, Mark, as I say, a number of those actions being embedded within the Safe Clean Care programme, but also in the infection prevention strategic group, which now reports directly into QSC. So many of those actions will be taken through via the IPSG reports up to QSC.
Okay, thanks, Jill. So the board are asked to note and receive the attached report, findings and recommendations, and to receive a progress report against each of the actions which is in the report and the update on Safe Clean Care. Are you happy to do so, colleagues?
Yes.
Okay, anybody else?
Yes.
Thanks, John. Okay.
Yeah.
Okay, thank you very much. Pedro point now, nurse staffing levels in terms of the tripartite annual report. Jill.
So again, Mark, this has gone through Quality Safety Experience Committee, and it is the report that the board are familiar with. There are some points I would like to make, most specifically for the minutes, to give the board assurance of the work that we are doing around the extension of the Act under Section 25B to include acute paediatric inpatient wards. So just to advise the board that all inpatient wards where Section 25B applies have been identified, and escalation and policies and business continuity plans have been reviewed and include references to actions to be taken to maintain nurse staffing levels within those wards. Systems have been put in place to record locally any deviation from the planned roster and to include the reason and actions being taken. And processes are in place to review and recalculate those nurse staffing levels on a 6-monthly basis using the national calculation template. So that work has been undertaken. The template on which the paediatric nurse staffing levels are to be displayed has been agreed nationally, and it will be in place for all our paediatric wards from October 2021. This will include ability for patients and families to access frequently asked questions regarding the staffing levels. Student commissions numbers were increased during preparation, and along with this outrun of newly qualified and additional recruitment, it is anticipated that the requirements will be filled by autumn 2022, but we acknowledge there will be a delay. Happy to take any questions on the report.
Hey, in request the NAI, any questions from anybody? No, okay. Thank you, Jill. So we note the updated report. We'll continue to support the ongoing recruitment and retention initiatives already in progress. And we note the PGS requirements in line with the revisions of the Nursing Staff Levels Wales Act. Are colleagues happy with me to agree those things?
Yes.
Yes.
Great, thank you, Giacomo Yao. So we are now going to break for lunch a bit ahead of time. So can I ask that you come back at 1:10, please, to resume? Thank you. Thanks very much.
I've declared a requirement for sandwich for lunch. Do you want a Marie kind of going to the shop?
No, all right. Yeah, okay. I'm fine.
You're not on mute, guys.
Here.
Okay, it's 1:10. I'd like to resume. So we are on to item Pedford Point Deg. Chris, are you ready to go into the pharmaceutical needs assessment?
Thank you, Chair. Yes, I am. In front of you is the final paper and document on the pharmaceutical needs assessment. This is a piece of work that was statutorily required to undertake and to publish from the 1st of October. The paper in draft form, or at least the P&A in draft form, has been to members previously, but since then we have been out for formal consultation as the regulations require. We've had a number of responses. In terms of gaps of provision, the paper also outlines by locality level where identified gaps or potential future requirements may lie. We now wish to publish this as our formal P&A, which will be in place for the next 5 years. I think the rest is in the paper, and I will open up for questions.
Thanks, Chris. Are there any questions? Can I just confirm, Chris, that where the needs assessment has identified potential gaps looking forward, that there's, I think the paper records, but I just would like to confirm it, that will form part of our planning process?
That's correct. Where a potential or real gap exists, then there is a well laid out process by which potential applicants could seek to plug that gap, but there is also a proactive responsibility for us from a planning perspective to identify how we'll meet those needs too.
Okay, thank you. So I don't have any other hands being shown. So are colleagues happy to note the outcome of the statutory consultation on the draft P&A, consider and improve the identified current and future gaps in provision, approve the publication by the 1st of October, the updated P&A document, and finally, no, that is the final point, I think, Chris. So those 3 things, are board happy to do that?
Yes.
Thank you very much. So, Chris. So we move on to adult and older persons mental health unit, Glenclwyd Hospital. Tracy has you down as the lead, but I'm expecting us to be joined by Ian, Mike, and Ian, I think. Are you, Tracy, leading us into this?
Thank you, diolch yn fawr. I'll speak in English to this item.
I can't hear anything. Do you know anything about Zoom?
As new
go and find the settings.
I'll go and speak to that office. You carry on, Tracy.
Thank you. I'll speak in English to this item as I've got colleagues kindly joining me today. So this paper's a paper that's already been through finance and performance, so it's had scrutiny there. And this is about the adult and older persons mental health unit. So what we often discuss as ABLET at present, but of course going forward we have an opportunity with this important project to be going forward to actually, with its new phase, maybe change the name and to change the discussion around the unit and to have that holistic view of mental health and well-being. And that's detailed within some of the papers as well. Rather than dwell too much, I just draw your attention to the 5 investment objectives that go alongside this paper. And of course, what we are trying to make sure is that we have a clinical model and a care model that aligns with the Together for Mental Health approach across Wales, and of course is best for our patients. That we have an environment which is clinically appropriate for our patients in this day and age. That it supports our recruitment and workforce activity. That it's about improving the quality of the environment on the estate itself. That one's key. And for those of you who visited the current unit, you'll know the challenges, and that's well documented here at board. And of course, the need for us to be flexible going into the future and for us to future-proof our services. So the papers here today, having gone through F&P, I have Ian and Mike from the division in terms of the clinical input and knowledge, and kindly Ian Howard, who supported us with a business case alongside Jill Timmins, who can't be here today, but has been significant in the development of the papers. The business case outline at this stage is on its way to Welsh Government, and I'm bringing it here today for approval so that we can take that next step, so we can have those discussions and hopefully get this build off the ground so we have a better environment for our patients in North Wales. Maybe I'll stop there and take questions with colleagues. Diolch yn fawr.
Diolch yn fawr, Teresa. Lucy first.
Diolch, Teresa. So there's evidence out there now that mental health services should be reducing the number of inpatient beds rather than increasing them. So how has the number of beds actually been arrived at? And have we considered the challenges that we're currently facing with young people at the moment and the provision of a transition-friendly environment for them?
Perhaps if I kick off and then I hand over to Ian and Mike as well. So certainly I've been having discussions with Jill Timmins, who's been checking out the situation across Wales in terms of the approach to beds. And I think given the current demand and some of our issues at the moment, there is mixed evidence on the need for the future. So there's probably differences in approaches across the country, but certainly we've looked at the bed modelling very carefully. We've considered our requirements, and we did touch base with a couple of health boards in the last few weeks just to check where they were, given some new bills elsewhere being discussed in Wales. And again, I haven't come across a reduction as such at this time. However, as we work, hopefully to the future, there are opportunities for us to change our thinking longer term. But at this stage, this unit will provide us with opportunities, hopefully, to work not only on the ABLET, but provide those regional services as well. Maybe I'll stop there and turn to Ian and Mike, Lucy.
I'm happy, Teresa, to pick up on a number of the issues, really. I think the national picture is that beds have been reduced significantly over the last 10 years, including ourselves over the years. And the picture is that we actually have a future requirement for increasing beds, that the current capacity is too low. One of the issues Teresa mentioned for future-proofing is that it would significantly reduce the need for out-of-area placements for people from North Wales, so that we can cope with, we'd have significant flex to cope with the significant demand. Plus what we know with COVID was the thinking that it's going to significantly impact on the mental health of our population in the long term, which will translate to a higher demand. Ian, I don't know if Ian wanted to add any.
No, I've got nothing to add to that.
And then on the children's, if I may, probably should respond to that one. Again, I worked with Jill to understand the requirements. My understanding is for the guidance for children's mental health facilities is different in terms of the advice. So there's a separate Welsh Health Building Note, I think that's what it's called, Ian, for Tier 4 CAMS units. And this redevelopment has been based on the adults guidance at this time. In terms of our activity and going forward, of course, we're at this OBC stage, which is, quite key for a capital project. And there isn't that much room for change once we get to this point, and that's important for board members to note and understand. And I know you'll be aware of that from other projects that have come through here at the moment. So at this moment, the guidance is completely separate and there isn't that precedent in place, Lucy. So we have checked it out with Jill, and that's where we currently are. But given the future, and in my mind, the new unit will be more holistic, will be more community facing. That's something that we are striving for. Hopefully we can continue to increase our links with the CAM service and build on the foundations and the work that we're currently undertaking. And Ian and Mike, of course, have updated you previously on the transition work which is underway.
So thanks for that, Teresa. Can I just pick up, this may just be my understanding here, so forgive me, but when you said there's little scope for amendment at this stage, I mean, what we're seeing before us now is very different. As we know, we've had discussions in other committee settings. It's very different from the outline business case that we received before a board. So if there is no scope for change now, I'm just wondering about the governance of that.
Well, this is the final point, is my understanding, where we can make those changes. I think I'm right in saying that, Ian. The paper that you received previously was at the SOC stage, the paper that came through board, and that was presenting a number of options. And of course, with each stage that we go through the business model, then there is a firming up of our approach and a getting more detailed in our plans. But as we move through this stage, and should we get the approval from Welsh Government, which is our aim, then of course we can consider a name. But in terms of the build and the design, we certainly are more limited from this stage forward, should it get approval from Welsh Government. Ian, can you help me out here in terms of the proper business stages for an OBC, the SOC, the OBC, and then to the FBC?
Sure, yeah, happy to do that. It's really essentially, as you've outlined, the strategic outline case is at concept stage with an indication of the way forward, but nothing definitive. The outline business case is where the organisation decides that this is the preferred option and has done, as you've seen in the case, a level of design around that to give us a high level of cost certainty. The next stage at FBC takes that design and does the very detailed design work down to the details of the rooms and so on. So essentially we spend a lot of time, effort and resource doing detailed design on this proposal. And what's presented as the FBC is then the final commercial deal and the final cost of the project. So I think Teresa's right to highlight that OBC is where the organisation makes its judgment about what its option is and what it wants to provide, and then goes and does the detailed design work on it.
Okay, thanks for that, Ian. That's helpful. I suppose I'm just wanting some confidence here that we're not missing a trick. That the I absolutely take your point about the inpatient beds, but we're also trying to change the pathways to actually reduce the need for people to be in an inpatient bed. And it's whether or not, are we investing in the right area here when we could be investing in our community services? But the second thing then is about I understand what you're saying, Teresa, about the children, but the young people, it's the number of 17 and 18-year-olds that at the moment we're seeing in our adult mental health unit, that we've had various discussions about it not being the right place for them, and whether or not are we just missing an opportunity to make a more transition-friendly environment for them?
Well, again, if I start, I'm confident that we've looked through the evidence and rechecked again in terms of the modelling, the numbers, and that we are future-proofing in a way the estate that we will have going forward. And we certainly need to improve on what we have. In terms of that young person's journey, that work that we are doing now currently between the CAMS team and the mental health division, I think will hold us in good stead. You are right in terms of demand and capacity at this stage. And interestingly, I was in a meeting yesterday where we were talking When will we see the peak in numbers coming through, given the current situation with COVID, which we know has affected people, but which will have a long tail in terms of our children and young people and the families out there. So I feel confident that we've considered those through the programme board and in discussions with other colleagues and other specialists. I don't know, Ian, you've been involved in the transition work considerably.
Sorry for my IT problems. Sorry, the point that I wanted to make, Lucy, and was that in addition to all the divisions transformational and programme.
Sorry, you're breaking up there, Ian.
Sorry. Can you hear me now? Sorry.
Yes, that's better. Yes.
Sorry. I was all I said was in tandem in relation to this work. Of course, there's the transformational programme of works that we're going to be doing that will touch upon as well. So I think there's both things going on at the same time.
Okay.
Lucy, in terms of transition, I think currently we have an age-appropriate bed identified in Headfan, and the reason it's been in Headfan has been because it's the best stop in terms of the estate, and the proposals here in the Ablett redevelopment give us much more individual rooms. So with young people in transition, we have a duty to keep them safe, and usually that means that we manage their care in an individual room. That would be much easier in this building than the current. Hygiene and other issues, other facilities available for people. So we would anticipate that transition, as they are in Headfan, could be more appropriately supported here. So we'll bring that extra resource for us in terms of our ability to manage.
Diolch yn fawr.
Diolch.
Joe and then Cheryl.
Clearly my Teams isn't working, my Zoom isn't working as I'm sat very clearly here, and yet you can't see me. I'll speak and then try and work on the technology. Just on the CAMS point, we have open discussions with our specialist commissioning colleagues in Welsh Government with regard to the building solutions on Abergele for our CAMS service, particularly with regard to our ability to try to be able to deliver a Tier 4 service. We also are aware that Welsh Government, from a specialist commissioning point of view, are working towards the development of a community-based Tier 4 service specification going forward, which will add to the range of options that we have for our children and young people. And apologies, I'll dial out of Zoom and dial back in again and see if that can resolve the technical glitches that we've got in Carlton Court today. Thank you.
Thanks, Joe. Cheryl?
Thank you very much, Chair. Well, Lucy raised all the points about the children and young people and the transition that are pressing for us. I'd like to say that I welcome the fact that any increase in beds is going to stop our patients going out of North Wales. It's long been the ambition to have them treated in their own area, in their own language, and I really welcome that initiative, so thank you.
Thanks, Cheryl. So just to confirm, Ian, Mike, Fraser, we're content that this addresses the future operational requirements. That was fundamentally Lucy's point. I know you sought to respond to that, and I can see you nodding. So I'm taking that as being the case. Ian, in terms of moving forward, planning considerations, given previous issues at the site, what's your view on that, please?
So we've had discussions with government at the level of certainty of planning required at OBC, and you'll see in the business case that there's attached an independent report confirming that the proposed change of location should meet the reasons why the previous submission was turned down at outline planning. So we've got independent confirmation that we've got a high level of confidence that planning will be successful when we come to the full business case stage. And subject to them going through scrutiny with Welsh Government are happy in principle with that level of assurance for us to move from OBC to FBC.
Okay, so is the board happy to approve the business case for submission to Welsh Government?
Yes.
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 Okay, thank you. Thanks, team. So we'll move on to the delivery of the primary care audiology services. Chris.
Thank you, Chair. You'll find in front of you a paper outlining how we propose to expand our primary care audiology service. I have to say, this has been a hugely positive piece of work in North Wales, which has been watched and reported internationally in terms of the role that our audiologists are doing. It's relatively it's available in small pockets, and what we're looking to do is to mainstream it, which is what this paper is about. Alongside this, we also are benefiting from the opportunity of having more audiologists in primary care to allow us to build an earwax management service. Earwax may sound trivial, but for those people that have been plagued from it, it is anything but trivial. So that in itself is an achievement for us. This paper has been through F&P. It has been an area of priority for us for some time, and so sits within our financial planning. So the funding for this has been earmarked and accounted for. I will leave the paper at that point and open up to questions.
Adrian.
Thanks, Mark. Just to support Chris really around things he said about the importance of this service. We've got, as he said, a world-leading service, really been visited by the Minister a number of times, and the introduction of the earwax management, which has been mandated by Welsh Government, really, really welcome, as he says, for those who need it. So just would like to support the paper. Thank you.
Thanks, Adrian. I have no hands. Yes, I do now. Lucy.
Sorry, Chair. I shall be quick. Chris, I'm sorry if this seems a really obvious question, but where will these practitioners be physically located?
In not every circumstance, but in most circumstances, we would seek to locate these individuals within primary care premises. Where that can't be achieved, and they need certain acoustic environments to be able to do proper hearing tests. So sometimes it's the size of the room as well as the availability of a room. Where that can't be achieved, we're seeking to position them in community facilities. They will be embedded in one of those environments within local communities.
Okay, thanks, Chris, because obviously we're placing a lot of pressure on our GP practices premises-wise at the moment, aren't we, with co-locating people. But my final point was about I understand, I think, from the options review, that a commissioned service is more expensive. But does that incorporate the costs and risk of recruitment and the other relevant on-costs that you'd get from us actually providing it, rather than, and what I'm thinking here is it's the way the service is commissioned in England, for example, is on the high street, so there's no impact upon us recruitment or workforce wise.
So I think you're referring to the earwax component to this. we had considerable debate amongst the team as to how that might best be delivered for a host of reasons, predominantly operationally in terms of building resilience around the service. We concluded that it was best delivered through the audiology programme rather than in individual high street audiologists. That's not the approach, as you say, that every provider has taken, but we were clear in looking at the work that the team brought to us that in doing so we would make both the earwax service and also the more high-end audiology service more resilient by bringing the two together.
Okay, thanks, Chris.
Chris, who's going to assume responsibility for the benefits realisation, which helpfully is documented in the business case?
So I have to say, I've worked with very few teams that are more engaged in terms of some of the detail than the folk that have been working on this. And therefore, whilst I'm pushing against an open door, the PMO will wrap support around them to ensure that we're absolutely clear about being able to demonstrate what we have achieved against our objectives.
Okay, thank you. Linda, did you want to pose a question to Chris?
Diolch yn fawr iawn, Cadeirydd. I'm here on Sam.
And apologies for the quality of my voice. Chris, could I please ask what the challenges are of trying to employ people who are bilingual in this new exciting service? I noticed that children and older people will be people who benefit from this service, but there are challenges already in trying to get people with this experience who are bilingual. So what is the challenge in getting bilingual staff? Thank you.
That's a fantastic question, Linda, and one that I'm not able to answer fully. But what I can say is undoubtedly there will be challenges, particularly in some of the more specialist posts within this, very much in the same way that we have challenges in recruiting GPs and dentists who can consult in a bilingual way. I think the point is well made in terms of when you're trying to do audiological assessments, that arguably is even more important. So I will go away to the team to explore that a little bit further. Thinking though, there are some posts within this, and certainly from the support roles, which actually we may be able to take a slightly more local approach in terms of how we identify our workforce, because there is an internal training component to that, rather than recruiting people that have been through graduate training schemes. So I'll go away to the team and try to explore that in greater depth, because I think it's a really valuable point.
And can you feed back to Linda when you have, please?
Absolutely. Yes, absolutely.
Okay, so are we happy to approve the implementation of the service across North Wales as described? Yes?
Yes.
Yes. Yes.
Okay, thank you very much. So we go on to item PIMP, which is the annual reports. Adroddiadau Blaenyddol. So the first is Jill's safeguarding annual report. Jill.
Thank you, Mark. We do have Michelle Denwood, who you'll be aware of, who leads on safeguarding. So I'm going to hand over to her to pull out the relevant parts of the report to bring to your attention, including the risk about dolls.
Okay, and Michelle, as you probably may have picked up, you can assume the report is read, so highlight what you wish though. Thank you.
Thank you. I appreciate this opportunity to present the annual report of 2020 to 2021, noting the progress and assurance. Within the report, you will see that there's also included the 3 key appendices providing the detail of within the report for safeguarding adults, safeguarding children, domestic violence, and sexual violence, and obviously the Mental Capacity Act and deprivation of liberty safeguards. I think it's fair to say within the report you will see quite evidence of a trajectory of activity and complexity within cases that have come forward, especially during the COVID pandemic. I think the team and the organisation have moved really swiftly in reviewing all policies, procedures, documentation, and implementing different activities to ensure that our service remains safe, that our service remains appropriate, and that we are safeguarding those who access our service as well as our staff and employees. And our multi-agency engagement remains at 100% in all of our activities, which is exceptional during this difficult time. I think it's clear to say when we're looking at the data, there was many concerns initially with the reduction in reporting from all agencies, and this is a national picture. But through the report, you will see that we have maintained that stable line of that trajectory, that we have maintained that reporting, and in some areas we've clearly increased that reporting figure. I think as well, we can see that we have provided assurance and some improvements throughout this period, and that's by our audit activity, very clearly in relation to domestic abuse and harm agenda, where we've absolutely utilised different practices to ensure that we are targeting vulnerable groups through our front door ED, as well as within our mental health services and those on the ward. And I think this has been evidenced in that reporting as well. And a national picture evidences that also. So we are in line with the national picture, sorry. And I think nationally it evidences that our governance and our accountability, we're scoring the highest score that we possibly can do so. I think it's really key that we are evidencing we continue to have challenges due to obviously the level and the complexity of safeguarding activity that both the pandemic has brought, but equally new and revised legislation. I think it's clear for the first time in Wales, we have legislation that legislates reporting of adults, which brings it for the first time on a same platform as a reporting of children. I think we still have a long way to go to improve on this on a national footprint. And I think forthcoming, which has taken us forward, is in relation to the deprivation of liberty safeguards, which evidently we are in a difficult position. The trajectory continues, the complexity is there. There are lots of elements where we are targeting, where we can identify improvement. But I think resource is a clear area of challenge for us. And in relation to that, the forthcoming legislation for liberty protection safeguards, of which sits under the Mental Capacity Amendment Act of 2019, really imposes national challenges for us, as well as our local challenges. So that is reflected in the risk register for corporate safeguarding, for both for DOLS and corporate safeguarding in its entirety. We have steps in place of where we are planning that clear implementation. Our obvious challenge is that we are still awaiting the code of practice to really give us that clear direction and accuracy And we are developing and will be signing off through the internal governance process the terms of reference for an implementation strategic group to implement programmes which will be required for the implementation of this new legislation. So I can see within this, within that period, and hopefully you can see the huge amount of work that's undertaken, the targeted approach that we are moving forward, and we've got that ability to do so, and that continued engagement. And obviously the action plan reflects that progress continues to be made, and we're working both from a clinical aspect for improvement face to face, as well as maintaining our strategic objectives. Thank you.
Thanks very much, Michelle. Any questions or observations? So you don't get away with, oh, John's come in, Michelle. So John, you first.
Thanks, Mark. I was just looking at the risk side of this. You highlighted a compliance risk and a risk against dolls, but I wasn't sure from the way it's been written whether the scoring, as you put it, is the inherent risk before your controls, or whether that is including the controls that you've documented.
John, that's including them controls.
Right.
So that is a significant risk for us. It is clearly there that we're obviously putting in additional controls to reduce that risk, but that is our current risk position.
Okay, thank you.
Jill?
It's just to support the work that's been undertaken on dolls, and Michelle and the team have been asked to report back at QSE in terms of progress and any further support they may need for the next QSE.
Thanks, Jill. I was going to say, Michelle, I wasn't going to let you get away with such a detailed report and no questions, but John helped me out there. But a couple from me, if I may. So, child at risk reporting, the figures are provided, aren't they? There has been a reduction. I note the references to face-to-face and so on and so forth. How concerned are we, or are we not, about the effect that the lack of face-to-face during the COVID period may have had on safeguarding and identifying children who may be at risk?
I would say moving forward, because obviously that was that data, where we are today from a multi-agency position, the information that we're receiving at the North Wales Safeguarding Children's Board and was referenced yesterday is that multi-agency, we are concerned with that reduction in face-to-face. I think we were aware and we were really concerned that unfortunately you don't identify the risks immediately with change. It then comes later, and this is the expectation in we're now evidencing that, and that's through the identification of harm and abuse, of which is looked at through the child practice review process. And I would say that is the same issues and level of concern that we have in the domestic abuse arena as well.
So from a multi-agency perspective, Michelle, if we are all concerned, is there any sense that the number of face-to-face meetings, home visits is set to increase?
Yeah, from a BCU perspective, we absolutely, through from the initial lockdown for BCU, we did recognise that there was an absolute reduction in that face-to-face. I think the Welsh Government advice was was misinterpreted, or it was interpreted differently in areas within BCU. We quickly grabbed hold of that with that support, and we opened that and ensured that there was a clear improvement, and we had a matrix of which our expectations were that face-to-face, and we provided that additional support. So from a BCU perspective, I can absolutely say from our frontline health visitors, school nurses, that engagement activity with CAMS, are absolutely from that first lockdown push forward with that face-to-face contact and utilise different methodology to support that in a safe environment.
And is that being mirrored by our social care colleagues?
I couldn't say it's 100% mirrored by our social care colleagues. I think we recognise that we've got 6 local authorities who all work very differently. Their priorities are different. And I think they recognise that we expressed some challenge in relation to the limited face-to-face contact and back in the office. And they're taking that forward as well and recognise that from, as I say, within our discussions.
Okay, thank you. So Morwenna wants to come in, and I've got a couple of other questions. I'll come back to those. So Morwenna, then Cheryl.
I just have a point on that and llawn cytuno
on that point. I agree with Michelle's point about the situation in the health board, but just to remind everyone that when during the period last year of the report, we were, of course, in a period of lockdown, and a lot of the references or referrals come from teachers and people who work with children, young people, leisure centres, youth centres. So it's not just about professional people making visits. Our referrals also come from the public, and as everyone was in lockdown and stayed at home, closed the door and not mixed, we did see those referrals dropping. But as far as social services and social workers, despite working from home, the visits, the normal visits to see families has not changed throughout the COVID. And if there is a need to visit, the workers have gone out to visit. But it's those initial referrals that has made that difficult for us, because without the referrals, there is no reason to knock on doors. So I hope that confirms the position. Thank you.
Cheryl?
Thanks, Chair, yes, and thanks to Michelle for this report. I know that the school nurses were redeployed at the beginning of the pandemic in some cases, which did cause some issues. But I know we've had a surge in referrals to local authorities, and Morwenna obviously has touched on that. But the face-to-face visits by local authority social workers did continue to take place. But of course, there was a greater area of wriggle room if there was a problem, because there was COVID issues being cited in non-compliance. So that's something to reflect on. Thank you.
Yeah, Cheryl. So a couple of other things from me, if I may, Michelle. There's reference, isn't there, to the outcome of child at risk reports and a random selection of 30 reports, with 8 of them being of poor quality, which I guess is around 30%. I don't know if that's high, but it does seem high to me. I know there's some further sampling to be carried out, but how concerned should we be about that?
I think we've been doing a lot of work on that. We're absolutely getting back down to a baseline approach. So what we are moving to is that when we're looking now at the All Wales procedures, the national procedures, it gives us a opportunity for that lead manager role, of which we'll be taking. So we'll be scrutinising the quality of the referrals prior to them being forwarded to the local authorities. This then will give us, again, greater ability to challenge that quality of that work. And I think that is some of the pressures at the front line about the quality of that reporting, but it doesn't support the assessment process which is required for local authority decision making. So it's at that point that we need that improvement, and that's what we're working through as well for this period.
Okay, thank you. And finally for me is reference to the safeguarding business case being a key priority for 21-22.
Yes.
Where are we with that?
And that'll be going to Jill. We made some additional amendments due to the information that was coming from the national group of the LPS. And then Jill and I will sit down and scrutinise that, be able to take that forward.
And the principal will go through execs once we've had that due diligence, Mark.
Okay, thank you. Right, thanks, Jill, and thanks, Michelle. So the board is asked to receive the annual report Are the board happy to receive the annual report and all that goes with it?
Yes.
Yes.
Okay, thank you. Michelle, thanks for all you're doing and also speaking to us about the annual report. And thank you to your teams too in what they're doing with partners around safeguarding. Thanks very much.
Thank you. Appreciate it. Thank you. Dr.
Okay, without further ado, we'll move on to the Welsh Language Services Annual Monitoring Report. Teresa.
Thank you, Chair. First of all, could I thank Eleri and the team for bringing this report together. The report has already been discussed and approved by the SPPH community, a committee, and I'm very pleased to come with the report to you today. There is a statutory duty to report upon the standards, and I believe that this report demonstrates the work and challenges that are ahead. But also the report is an opportunity for us as a health board to demonstrate what we're doing generally and the progress that we're making in relation to the Welsh language. And I'm very pleased with the number of reports that are coming in within this report showing the progress that has been made during a pandemic year, of course, so a real challenge. I won't go through all of the standards, but I would draw the attention of the board to the progress in relation to standard 63, the assessment and the educational courses, and also standard 37. There will be an update on that in the new year. That's on the action log for the health board. I'll pause there, but I do ask that you approve the content of the report so that it can be sent to the Commissioner's office to report on the excellent work that is taking place. Thank you.
Teresa. Any questions or observations? Linda, anything from you as our Welsh language champion?
Thank you, Chair. Could I just agree with what Teresa has said today? It is a report to be congratulated, given how hard the team have had to work. And the progress has been made is to be congratulated. But the only concern I would possibly raise is that it's important for us as a board to look at how much resources is given to this team. The team isn't large, and I don't want to feel that that we lose the goodwill if we ask the team to achieve more than is possible for them to do so with the resources currently available. But in doing so, and in saying so, I do believe that the excellent work that the team has achieved is to be congratulated as a board. Thank you.
Yeah, Linda. So, Trace, on the point of resources, we've discussed that before, haven't we? And also, particularly in terms of translation, as I understood it, a further assessment was going to be carried out, particularly around board papers. So, does that remain the case?
Yes, you're right, Chair. At the moment, Eleri is looking at the assessment in relation to standard 37, but as part of the conversations and with the support of the team, we are now looking at the requirements for the team, the priorities, and what is needed to sustain the service so that we have the best services for our team, and then enables us to give the right offer in relation to the language, and that we do work totally bilingual as a team. Eleri and her team are moving ahead with this work, and when that goes to the exec team, I will be back.
Okay, and in a recent meeting with the Minister, Teresa, she asked chairs to give an update on the commitment of health boards to more than just words. You and the team helpfully provided me with an update in that regard. Are you content that we remain focused on more than just words, as well as, of course, the standards?
Yes, certainly. I feel what we're ahead, and we should be very proud. But I remember someone saying that we could do better still, and as a team, that's where we're at. We want to do more. I feel that there is an interest from the board more than ever in relation to the work with the Welsh language, and as a whole across the board. And I do feel that there's more to be done, but I do feel that the challenge has been set and that we're persevering, and I'm grateful for the board's support and your support so that we're still ahead in Wales. But I hope that everybody catches up and that it drives us further still. I know that we need to do even better. I think we need to do more in due course.
Okay, diolch yn fawr. Morwenna.
Thank you, Chair. Just to support the points that Teresa has made, I think it's in the report and in the internal forum that we have. We also have the More Than Words Forum for North Wales, and this is one of the ones. I hope I don't offend people across Wales, but I think it's one of the most active across Wales. And when I attend the partnership board nationally with Welsh Government, I hear of the excellent work that is taking place in this health board. But going back to the forum, the cross-partnership forum that we have in the North, there is excellent work taking place to share good practice, and I can provide assurance to the board that the contribution officers make from the health board is very much appreciated, and I very much look forward to collaborating some more on that forum and making the improvements, as Teresa said, for the future. Thank you.
Diolch, Morwenna. So on that note, a very positive note, we are asked to approve the report. Are we content to do that?
Yes.
Okay, thank you very much. So we'll move on again then. So Pimp Point Tree, the annual consultation summary. Louise, we're asked to note the report, but before I ask colleagues to do that, is there anything in the report you want us to particularly note or highlight?
No, I don't think so. Thank you, Chair. It's just the annual reports setting out the range of consultations the Health Board has responded to in the financial year.
Thank you. Are you happy as board members to note the report in question?
Yes.
Yes.
Thank you. So moving on. So we are moving into closing business. Before I come on to the new items that are listed as a result of the governance review, Adrian, I think there's something you wanted to highlight to board members.
Yes, please, Mark. Sorry, I just wanted to change that background. So I'm going to take myself off the screen for a moment. Like disappearing. Thank you. I just wanted to take the opportunity when we're all together to highlight that it is National Organ Donation Week this week, and to recognise the huge positive impact that organ donation has, not only for those who receive the donation, but also in the act of giving at a time of deepest personal loss and grief, and many families who've donated talk about this. So the plea this year is to have the organ donation heart to heart. There is a focus on having the conversation with relatives and leaving them certain regarding our wishes. Families are always involved before organ donation goes ahead, and we're encouraging everyone in the family, whatever their age, to have a conversation about organ donation, so that when the time comes, families are certain about wishes. I'd also like to thank our teams who've continued to work across the organisation during COVID, and they work in EDs, ICUs, theatres, for going above and beyond, working tirelessly to support patients and families, always with care and compassion. In the year 2021, they helped to facilitate 16 donors, with 35 patients receiving life-saving or life-changing transplants. And I think it's worthy of note that all who have attended from external organisations have nothing but praise for our staff. To promote Organ Donation Week, yesterday a number of our team walked up Snowdon with donor family members and photographs of donors to remember them. I've got some photographs. I'd just like to say diolch yn fawr iawn pawb for doing that. An energetic day for many of them. We do hold an annual celebration of organ and tissue donation to remember those who have donated and those who have received donations. And this year it will be hopefully at St Asaph Cathedral on Saturday the 13th of November, and all are welcome to attend. Diolch yn fawr, Chair. Thank you very much.
Thanks very much, Adrian, for highlighting, and I'm sure the board endorsed the observations, comments, support you offered in respect to the people involved. Could you circulate that date so we're all aware of it, please?
I will do, Chair, absolutely. Deal.
Yeah. So I'm going to move us on then to the final items for the public session. The first is to consider any items to refer to committees. I'm not sure that we've picked any up, but I'm sure that if there are items to be referred, we'll do that through the minutes and the action table, Louise and I. But stop me if you want me to. Review the risk highlighted within the meeting. I'm not aware, other than those items that we discussed, that we just need to discuss that item anymore. But again, I'm prepared for you to say otherwise. Louise.
Thank you, Chair. I just really to confirm that this is a new short item at the end of each of our board agendas that just gives us the opportunity to reflect on the risks that we've discussed today. And I've sort of noted some pieces as we've been going along. And I guess the sort of takeaway on this is really just to ensure that risks around vascular urology and some of the other items that we discussed today are appropriately reflected on the risk registers. They are, but it's just to kind of have that flow through into the risk management group. So just wanted to add that.
Yeah, that's helpful. So you and I, between us, I'm sure will capture any that need to be registered if they're not registered already. And then in terms of the next item, review of meeting effectiveness, is there any observations colleagues would want to make about how this meeting has gone, or how we might improve its effectiveness at this point? Lynn.
Hi, thank you. I've just found that there's been some duplication in the papers that have been presented to committee as well. And I'm not quite sure whether it is just absolute duplication or we could have given a shortened version today.
Okay, all right. An example, Lynn?
Sorry, you know, I haven't got it. Sorry, I'm flummoxed now because it was just a general comment about a number of the papers that had been to QSA or SPP&H.
Okay, all right, thank you. Okay, Linda, then John.
Ymddiheuriadau, mae llaw fi wedi diflannu, Cadeirydd.
Apologies, my hand has disappeared, but one thing that struck me today was timely papers to make decisions. I know there are challenges to get current paperwork, and you've already mentioned, but as a general thing, this is something that we should be discussing possibly.
The translation. I might. What are you asking us to review? I missed that. Sorry.
It's not a problem at all. Sorry. It was just one general comment with Lynn that struck me today, and one which you've already referred to, was the need for us when taking decisions to have papers that are timely. And perhaps that's something we can consider as a board for future meetings, is to discuss with colleagues what's realistic. It was struck me with the 30th of June paper. If we are taking decisions or having discussions together, it would be helpful to have that update. So I was to reinforce, I think, a comment you'd already made, that I very much agree with that. And it was a general comment that struck me from our discussions today. Yeah, thank you.
Yeah, Linda. Lucy, then Joe.
Thanks, Chair. It's just really supporting what Lynn said. I know Lynn wasn't in the development session with us yesterday, but just reflecting on the conversations that we had yesterday. And there were a number of reports today that have, in their current form, have actually been through a committee before. So you've got the business cases, you've got the plan, you've got the annual report for safeguarding, the vascular report. So they're kind of examples of in exactly the same form they've gone through committee as well. And I just wonder if there's again reflecting on our presentation yesterday, whether there's a way we can be a bit smarter about that.
Certainly, that's something I've raised with Louise, and Louise and I will pick up. Thanks, Nancy. Joe?
Oh, still can't see me. Okay, I'll ignore the fact that you can't see my face. I just wanted to make a comment in a different kind of space, and that is that I have really appreciated the way in which Mark has chaired the meeting, enabled all to make comments and have made our guests feel incredibly welcome. It's a big meeting to come into, and I can remember joining board meetings as a non-board person. It can be quite daunting. So I think just making sure that we're kind and appropriately challenging to our guests is a real skill. So thank you, and to colleagues, thanks for providing an environment which feels safe. Diolch yn fawr.
Great, diolch yn fawr, Joe. So I'm going to move us off of that then onto the summary of private board business to be reported in public. Are colleagues happy to note the report?
Yes.
Thank you. So date of next meeting is the first CHE Didegin Hydref, and the next meeting of this board in Degwydd Tachwedd. So they are the dates of the next meeting. So without further ado, I will move to the exclusion of the press and public from this meeting, and we'll move to the private session. Can I just remind you, you all need to dial out and dial back in into the other meeting software. So diolch yn fawr iawn. Thanks everybody. Thanks for your engagement, involvement in the public meeting, and I look forward to seeing you again.